Hi everyone, a very warm welcome to all of you guys. Myself, Dr. Vaibhav Jain, and today we will be discussing about dermatology. Please let me know in the chat section whether I'm clearly visible and audible so that we can proceed with this wonderful session, guys. Please let me know. All right. Yes, that would be enough for FMGE as well as NEET PG. I have incorporated questions from NEET PG, INI set and FMGE examination. Okay, very good, very good. So let's begin, guys. So what would be our class today? What we are going to do today, we are going to see each and everything in a very short span of time. Okay, I have incorporated all the important questions. I have incorporated all the important things that are useful for your examination. Okay, so feel free about anything, guys. At the end of this class you will be understanding dermatology in a very good sense. Okay, even if you have not completed, that would be very helpful for all of you. Okay, so we are going to study in a form of a story, and we are going to study in a form of, like, everything is well systematic. Okay, so we will be starting off with the basics of dermatology. सबसे पहले we will be discussing about basics, then we will be studying about skin appendages. What are the important questions that are coming from particular topic? I have incorporated those questions at the end of topic. Okay, so whatever we are learning here for the next 3 hours or 2.5 to 3 hours, what you guys will be doing, you will be learning here itself. Okay, if you have come here, we will be learning each and everything here. Okay, so what are the skin appendages? Those structures which are present on your skin. Skin के ऊपर जो भी होगा, whatever structures are present in your skin will be covered under skin appendages. Your nails, your hairs and your glands will be there. Okay, apart from that, then we are going to move on to next topic, that is your papillosquamous disorder. That would be covering your lichen planus, your psoriasis group of disorder. Very important, every year questions are coming from them, right? Then we will be discussing about the certain types of infections, all the bacterial, viral, fungal and parasitic infections. Okay, apart from that, we are going to study about the STD, which is a very important thing. Just by looking at the ulcer, you will be identifying after this class that what ulcer is that and how you will be treating. That is also connected with your PSM part. Okay, we will be discussing everything. Okay, then we are going to see about the vesicobilous disorders, the meaning of pemphigus, what is pemphigoid, all those things will be clear to you, right? Then we will be discussing about some hypo and hyperpigmented disorders. Okay, hypo and hyperpigmented disorders, and ultimately we are going to do some miscellaneous topics. Miscellaneous topics mein kya hoga? What are the things which are left here, they will be covered there. Okay, these are my Instagram and Telegram. If you want to connect for any questions, any doubts, you can always reach out to me. Okay, so without any further delay, I think we should start now. So give me a quick confirmation that you guys want to learn something new. Okay, very good, guys. I can see lots of you are commenting. So please try to be interactive till the end of the session. I want you guys to be interactive with me. Okay, so please try to be interactive, try to answer whatever I am asking. Okay, so first thing, let's start with the anatomy of the skin, guys. How many layers do we have in the skin? Before that, can anyone tell me what is the largest organ of the body? Largest organ of the body. Largest organ of body. We will be starting with the basics and then we will pick up the speed. Okay, sara khatam hoga, don't worry about anything, you just have to answer me. Okay, so that would be your skin. That would be your skin, guys. Okay, second thing, how much is the weight of the skin? How much is the weight of the skin? How much is the weight of the skin? Sir, it depends on person to person. Okay, some people are having 4 kg to 5 kg of skin, right? But the question that they have asked you in your examination, that is how much is the area that is covered by skin. They have asked you the question, how much is the area that is covered by skin? Then your answer would be, guys, 1.722 to 2 meter square, and this was the question they have asked you. Okay, whatever question they have asked you, I would be marking them, right? So this is the question they have asked you. Now, can anyone tell me how many layers do we have in the skin? How many layers do we have in the skins? कितनी layers होती है? How many layers do we have? Sir, we are having epidermis. That is the outermost layer. Epi means above. Above what? Above dermis. So that would be your epidermis, and something must be below dermis, right? So that would be your hypodermis. That would be your, guys, hypodermis. Okay, so we are having epidermis, outermost, then there will be dermis, then there will be hypodermis. Sir, between epidermis and dermis, there is a region that is known as dermo-epidermal junction. So that would be a junction between epidermis and dermis, and that is very important. I'm telling you these basics so that you can understand the pathology well. Okay, we will be discussing about bullous pemphigoid, all those things. So that would be very, very clear if you understand these things. Okay, so sir, outermost layer will be epidermis, then there will be dermo-epidermal junction, then there will be dermis, and then there will be hypodermis. Okay, can anyone tell me how many layers do we have in the epidermis? Okay, very good. Nani, Ankit, Sneha, Nidhi. Okay, so how many layers do we have, sir? We are having, we must be hungry by now, so we can remember the mnemonic. Come, if you are hungry, then come, let's grab some burger, right? Come, let's grab some burger. And this is how we remember the layers. Okay, so what are these layers? First of all, try to understand the meaning. If you know the meaning in dermatology, if you know the terminology, your life will be easy, guys. For example, we will discuss about herpes. So simple meaning of herpes will be grouped vesicle. So whenever you will see grouped vesicle, I would be telling you what is a vesicle, right? So these are simple terms. If you understand the term, your life will be easy. So meaning of stratum will be a layer. Okay, so first layer will be stratum corneum, guys. Stratum corneum. Second layer, which one? Very good, you guys are already answering me, right? Wonderful, wonderful, guys. That is your lucidium, then your granulosum, then your spinosum, then your basal. So we are having these basically 5 layers. Okay, then can anyone answer me what is germinativum? Sir, basal is also known as germinativum. Okay, germinativum. And when both these layers, stratum, spinosum and basal, they are coming together, this is known as Malpighian layer. Okay, so these are the basic terminologies that you should be knowing. And one more thing, in all the body you will be having 4 layers. Okay, this lucidium will be present in palm and soles. This lucidium will be present in palm and soles. That is why palm and soles are thick enough. Okay, let's see one by one what are these layers, guys. The first one is your stratum corneum, then your lucidium, then your granulosum, then your spinosum, and lastly we are having basal. That is, come, let's grab some burgers. Apart from that, what are different things we are having in the skin? We are having some cells. Okay, can you appreciate this dendritic structure, guys? Can you appreciate? So this is a dendritic cell. This is melanocyte. Can anyone answer me what is the function of melanocytes, guys? Okay, and this one is your Merkel cell. Merkel cells are basically type 1 slow adapting receptors. They are touch receptor, guys. They are touch receptor. Okay, and this is a sensory neuron. So we are having keratinocyte, we are having melanocyte, we are having Merkel cell, and one more cell is also there, that is your Langerhans cell. So basically we are having how many cells? 4 cells. We are having 4 cells. Okay, so we will be discussing one by one about all the cells. Okay, so the first one is your keratinocytes. Can anyone tell me what is the function of keratinocytes? Keratinocytes are the most abundant cells. Some of you are moving very forward, right? Answering me. Okay, that is most abundant cells. Most abundant cells will be keratinocytes. How much is the keratinocytes, guys? That is your 95% of the cells will be keratinocytes. They will be present in all the layers, Okay, and what is the function? Of keratinocytes? Very good, Nani. That is vitamin D synthesis. Okay, vitamin D synthesis. Apart from that, what is the other function? Vitamin D synthesis. What else? It will be providing protection. It will be providing us the protection. And where does this layer is coming from? It is derived from which cells? It is derived from ectoderm. It is derived from ectoderm. Okay, so this one is your ectodermal in origin. Okay, next one is your melanocyte. Melanocytes का function क्या होता है? Try to answer, guys. I can see any a Nani. So that is your, it will be secreting not melanin, guys. It will be secreting melanosomes. Keep your concept clear. Okay, it will be secreting melanosomes, and melanosomes will be secreting what? melanin. How many types of melanin do we have, sir? We are having eumelanin, we are having eumelanin, we are also having pheomelanin. Okay, so we are having eumelanin, we are having pheomelanin. Okay, eumelanin, the function, sir, simple. It will be giving which color? Black and brown color. It will be giving black and brown color. Okay, whereas pheomelanin will give white color. Okay, white color. Sir, what is the clinical importance of this particular thing? So clinical relevance of this melanin, remember, this melanin will be helping us to give color, first thing. Second thing, important function, it will be providing protection against UV radiation, ultraviolet radiation. So those people who are black people, they are at a lesser risk of having skin cancer. Okay, because this particular melanin will be providing some kind of protection, right, apart from color, right? And we are also having one classification, that is Fitzpatrick classification. So try to understand, this is a melanocyte, it will be giving what, sir? It will be giving your melanosomes. Okay, these are your melanosomes. They will be having melanin pigment inside, and those melanin pigment inside will be giving color to multiple keratinocytes, right? How many keratinocytes it will be giving color? So one melanocyte will be giving color to how many keratinocytes? Try to answer, guys. One melanocyte will be giving color to 36 keratinocyte. 36 keratinocyte, and this is particular thing is known as epidermal melanin unit, and this is the exam question they have asked you, right? So this is the exam question they have asked you, that one melanocyte will be giving color to 36 keratinocytes. Okay, okay, wonderful, guys, wonderful, very good, Annie, right? So basically this is about it, right? Where does this cell is coming from? It is derived from, second question that they have asked you, where does this cell is coming from? So sir, this cell is coming from neural crest cells. Okay, this melanocytes are coming from neural crest cells. Okay, neural crest cells. Third one, very, very important, guys, very, very important. In the right, can you appreciate this type of appearance? What is this appearance? Try to answer me. Okay, these are your Langerhans cells. Okay, they are present in stratum spinosum. They are present in stratum spinosum. Okay, and what are basically Langerhans cells, sir? They are basically macrophages. Okay, they are macrophages of the skin. Okay, they are macrophages of the skin, or antigen presenting cells of the skin. For example, we are having macrophages. These are basically monocytes. Monocytes kahan se aate hain? We are having monocytes in the blood. If these monocytes are present in liver, we call it Kupffer cells. If these monocytes are present in your bone, we call it osteoclast. Okay, they are present in your kidney, they are known as mesangial cells. Okay, so basically they are monocytes, and when they are going to different organ, they are known as they are known by different names. Okay, so these are basically antigen presenting cells. Okay, where does these cells will come from, sir? These cells will come from bone marrow. These cells will come from bone marrow, or you can also call it, they are mesodermal in origin. Mesodermal in origin. So basically they are formed in the bone marrow. Monocytes bone marrow mein banenge, and then they will be transported to the different parts of the body. They are formed inside the bone marrow and then transported to different parts of the body, but performing a similar function. They are all macrophages, right? So what is this structure that you will be finding along with this? This is known as very good, tennis racket appearance. Very good, Kaushalya, Sonam. So that is known as Birbeck granules. These are your Birbeck granules. Okay, these are your Birbeck granules. And what is the structure? What is the shape? That is your tennis racket appearance, guys. Tennis racket appearance. Tennis racket appearance. Okay. Next thing, what are the markers? They have asked you question on the basis of marker. This is an important thing. For example, in medicine also, you will be correlating this particular thing. You will be having Langerhans cell histiocytosis. Okay, histiocytosis X, right? What will be happening there? There will be increased levels of these Langerhans cells. Okay, what are the markers? Try to answer. What are the markers? Markers are CD1A. Try to speak with me wherever you are. Try to learn things. Okay, we will be revising everything. We are just one more cell away, right? So that is your CD1A. Second one is your CD207. Okay, CD207 is the most important marker. This is most important marker. This is also known as Langerhans. Question has been asked on this, right? This is an important marker. Okay, next one, very good. S100 can be there. S100 is non-specific, guys. Okay. Next one is your Merkel cell. Merkel cells are basically type 1. They are basically type 1 slow adapting. They are basically type 1 slow adapting touch receptor. They are basically type 1 slow adapting touch receptor. They are present in your which layer? We have already discussed. Two cells will be present in the basal layer. Okay, first we have seen about the melanocyte, that is your melanocyte, and second cell that we have seen is your Merkel cell. Remember guys, question from physiology. Merkel cell will be present in epidermis. Okay, Meissner's corpuscle will be present in dermis. I would be telling you how. Okay, this is important question that they will ask you in physiology. Okay, we will be integrating multiple subjects together. Okay, we will be integrating micro and all also. Okay, so these are basically type 1 slow adapting touch receptor. They are touch receptor. Okay, they are coming from which layer, sir? They are coming from ectoderm. They are also coming from ectoderm. So let's revise whatever we have studied till now. We will be revising each and everything, and we will be making a table, and you guys will be helping me to make this table. Okay, so try to answer. Keratinocytes, where does it originate from? Wherever you are try to speak, sir, they are coming from ectoderm. Okay, they are ectodermal in origin. This is the table that you need to see just before your examination, be it your FMGE, INI, any examination, questions are coming from this, right? So whatever questions are coming from this, I have incorporated. Okay, second thing, what is the location? Sir, keratinocytes will be present in all layers. They are present in all layers. They are present in all layers. Okay, next thing we are having, what it would be secreting. It would be secreting keratinocytes, sir. It would be concerned with the keratin something, right? So it will be having keratin, right? Next one, what are the marker? Marker is important, that is cytokeratin 14. Okay, cytokeratin 14. Remember guys, keratin is a marker for what? Try to answer. Okay, what are the functions? We have already discussed. First function, that is your vitamin D synthesis. Second function, it would be providing protection. It would be providing protection. Very good, Sneha, Kushalya, right? Next thing is your melanocyte. Melanocyte will be secreting what? Melanocyte will be secreting melanosomes. Okay, melanosomes. They are present in which, they are coming from which cells, guys? They are coming from neural crest cells. Neural crest cells, you must have studied about neural crest cells in your anatomy, in your embryology section. Okay, so this was the question they have asked you about. The melanocytes are coming from, so they are coming from neural crest cells. Okay, next one is about your location, guys. Location, they are present in stratum basal. We have already seen two cells will be present in the base layer. First one is your this melanocyte, and second one is your this one, Merkel cell. Okay, so these two cells are already present in the basement layer. Okay, basal, stratum basal. Okay, next thing, what are the marker? They have asked you question on the marker. Which marker is that, sir? First one is your Milan A. Second one is your HMB 45, and third one is your non-specific, that is S100. So they have asked you question based on this. Okay, this is also important. Okay, what are the functions, sir? They will be providing melanin, and melanin ka function we have already discussed. It would be giving color, and it will be giving UV protection. It will be giving color, and it will be giving UV protection. So these are the important things about this particular thing, right? Next one, Langerhans cells, sir, it is mesodermal in origin. We have already discussed, that is coming from the bone marrow, right? Second thing, it will be majorly present in your stratum spinosum. If you understand these basics, what I am teaching you basics, if you understand these basics, your life will be easy. Dermatology will be very, very easy for you. Till after 3 hours, you will be understanding each and everything. You will be solving approximately 90% questions that are in your question banks. Okay, what would be secreting? It would be secreting, sir, Birbag granules. It would be secreting Birbag granules. Okay, Birbag granules will be having what kind of appearance? That is your tennis racket appearance. Okay, what are the markers? Markers are CD1A and CD207. We have already discussed, and they are basically macrophages of skin. They are basically macrophages of skin, guys. Okay, next thing about Merkel cell, they are ectodermal in origin. What they would be secreting? They are secreting neurotransmitter, because they are type 1 slow adapting receptors. Okay, so they would be secreting neurotransmitter, and their marker will be CK20, that is cytokeratin 20. And what kind of touch sensation they will be carrying? They will be carrying, guys, crude touch. Okay, crude touch किसका होता है? What is the pathway for crude touch from physiology? Try to answer what is the pathway for crude touch. Okay, so this is pretty much about the table that we are having. This is the question they have asked you. I am marking those questions that they have asked you. Okay, these are the important things that you should be remembering. Okay, these are the important things that you should be remembering, approximately 4 to 5 questions from this particular table. Okay, next thing, let's talk about the layers. What we have seen till now, we are having skin will be having epidermis, then there will be dermis, then there will be hypodermis. So in epidermis we have already covered with first thing, that is the cells. We are having 4 types of cells. Try to revise. We are having keratinocytes, we are having melanocytes, we are having Merkel cells, we are also having Langerhans cells. So these 4 cells we have already discussed. Now we will discuss about all the layers. Okay, one by one we will be discussing about all the layers. Nowadays questions are coming from histology part also, so you need to understand how to identify. First of all, can you appreciate this is the stratum corneum? What was the mnemonic that we have seen? That is come, let's grab some burgers. So that is corneum, lucidium, granulosum, spinosum, and basal. Okay, so these are the layers. Okay, so we will start with the uppermost layer, that is stratum corneum. Sir, it is devoid of nucleus, so there will be absence of nucleus. There is no nucleus. And remember, if there is no nucleus, that means we will not found any blue color structure. Nucleus will be giving you which kind of a structure? That would be giving you blue color structure, right? So look here, these cells are nucleated. You will be having nucleus, here also, but stratum corneum is devoid of nucleus. Point number 1 that you have to remember, stratum corneum is devoid of nucleus, so there will be no nucleus. First thing, done, right? Second thing, we are having lucidium. Lucidium में क्या होगा? You have to remember about lucidium. You will be having this layer, and this is a clear cell layer. Okay, clear cell layer. Third layer we are having is your stratum granulosum. Can you appreciate these granules? Yes, we are having these type of granules, so that is your granulosum. Okay, then you will be having fourth layer, that is your spinosum. They will be having these spine-like connections. Okay, they will be having spine-like connections. Okay, that is your spinosum. And lastly, we are having stratum basal, will be having melanin pigment. We have also already seen 2 things will be there. One is melanocyte, second one is your Merkel cell. Okay, Merkel cell. Try to remember with me what we are learning, right? Then coming the basement membrane, that is basement membrane is also known as dermoepidermal junction. Okay, and then coming this dermal papilla. Sir, what is this dermal papilla? Dermal papilla we don't know. So you must have heard about rete ridges and dermal papilla, right? So what is rete ridges? What is dermal papilla? Let me clear it for you. So whatever part of epidermis, sir, above will be epidermis, then there will be dermoepidermal junction, and then there will be dermis, right? So whatever part is above is epidermis. When epidermis is invaginating into dermis, right? This is the part of epidermis which is going into dermis. This is known as rete ridges. Simple, right? When the dermis is trying to invaginate into epidermis, this is known as dermal papilla. Simple things, guys. Okay, simple things. Sir, uppermost part is epidermis, lowermost is dermis, between is dermoepidermal junction. And when look here, so this is the part of epidermis, this is your epidermis, and it is trying to invaginate into dermis. So this is known as rete ridges. Okay, try to understand. And this part will be dermis, and it is trying to go into epidermis. This part is dermis. Look here, this is the cells of dermis. So this is trying to go into the epidermis. This is known as dermal papilla. Clear for everybody? Okay, clear, right? Do let me know also that you are understanding. Okay, so is that clear for you? If you are having any doubts also, you can always ask me, right? So this is for the dermal papilla. Okay, I have already told you about the Meissner's corpuscle. That would be present in your Meissner's corpuscle will be present in your dermis. And which part of dermis? That is dermal papilla. Can you appreciate these cells? These are your Meissner's corpuscles. Okay, and which structure is this? This is dermis. This is, sir, dermis. Okay, so we are having these things you have to remember about. Okay, Apart from that, please remember this desquamated cells. Okay, these desquamated cells are present here. Okay, basically stratum corneum is shedding off here. Okay, and these cells are making what scales. So whenever we will be studying about all the scales like silver white scales, we are having brainy scale, rice powder scale. Okay, any kind of scaling we will be discussing, they are basically desquamated cells. Okay, so that time I would be asking you what is this desquamated cells. Okay, apart from that, everything is clear till now. Okay, is that fine? Are you guys understanding? One more thing I want to teach you, that is desmosomes. Okay, what, suppose this is a keratinocyte, this is another keratinocyte. Basically, we are having cells, right? These are keratinocytes. So what is happening? Sir, these two keratinocytes, for example, this is a keratinocyte, this is also a keratinocyte. These two keratinocytes are binded together with the help of a thing that is known as, what is this thing, sir? Please try to answer in the comment section, bacho. Please answer in the comment section. What is this? This is a keratinocyte, this is another keratinocyte. They are binded together with the help of what? What is this? This is, sir, this is nothing but your desmosome. And they are desmosomes. Very good, Sneha. So these are desmosomes, and these are maximum present in your stratum spinosum. These are your desmosomes. These are your desmosomes. दो keratinocytes कैसे जुड़े होंगे? How they are connected? Two keratinocytes are connected with the help of desmosomes. Okay, done. We will be studying about desmosomal disorders. First of all, we will cover up this thing. Okay, so we will be discussing about the peculiar features that has been asked in your examination from these particular layers. Okay, so first of all, we are having stratum corneum. First thing that we already know, sir, it is devoid of nucleus. It is devoid of nucleus. So there will be no presence of nucleus. If there is no presence of nucleus, the layer will be pink. Okay, there will be no blue structure. First thing. Second thing, sir, it will be absent in preterm babies. Preterm babies or very low birth weight babies. Okay, very low birth weight babies will be having no stratum corneum. Okay, they will be having this layer absent. Okay, third thing, maximum keratin will be present in this particular layer. Maximum keratin will be present here. Okay, second thing we need to remember about second layer, that is your stratum lucidium. First thing I have told you that it will be present in your palm. It will be present in your palm and soles. It will be present in your palms and soles. Remember, both of them are having L. So you can remember lucidium will be present in your palm and soles. Lucidium will be present in your palm and soles. It will be having what, sir? It will be having refractile granules. It will be having refractile granules of alludin. It will be having refractile granules of alludin. Okay, it will be having refractile granules of alludin. Two things you have to remember. First, it's stratum corneum devoid of nucleus. Second thing, that is absent in preterm babies, and it will be having maximum keratin. Lucidium, you have to remember, they will be having which granules? Alludin granules. Okay. Second thing, stratum granulosum. Stratum granulosum, naam mein hi likha, it is written itself, right? Granulosum means what? It will be having certain granules present. Granules will be there. Okay, so we are having two types of granule. One is keratohyaline granule, second one is membrane coating granules. Okay, so this keratohyaline granules will be converting this profilagrin into filaggrin. Okay, filaggrin, the meaning of filaggrin is nothing but filamentous aggregating protein. Okay, you can remember like that. It will be helping in the filamentous aggregating protein. And if there is a disease, if there is absence of keratohyaline granules, there will be some disease. This one is your ichthyosis vulgaris. Can you appreciate? This is your ichthyosis vulgaris. This is your ichthyosis vulgaris. What you will be seeing? You will be seeing fish-like scaling. Okay, ichthyosis, the meaning will be fish-like scaling. Fish-like scaling will be there. Okay. Second thing that can happen is your atopic dermatitis, guys. Atopic dermatitis. Okay. Dermatitis means what is? That is the inflammation of the skin, right? That are the two diseases that can happen over here. Second thing, membrane coating granules. Simple thing you have to remember, sir, this layer will be making what? Lipids. This one will be making lipids. If there is no lipid, what will happen? There will be, if lipids are absent, what will happen? There will be Dryness. There will be dryness. And which disease will occur? This is known as eczema. This is known as eczema. Okay. Can you appreciate this thing? This is your eczema. This is your eczema. And what is this specifically known as? This is your winter eczema. This is winter eczema, also known as astiotic eczema. Astiotic eczema. Okay, this is your winter eczema or astiotic eczema. How do we treat this particular situation? Sir, there is dryness. We can give some kind of a lotion, right? We can give a moisturizer, right? So that is your lactocalamine lotion you can use, and that would be helpful in this particular situation. Okay, in this particular situation. Okay, next one is your stratum spinosum. First of all, stratum spinosum. Spine means what? There will be some kind of spine-like structures. Okay, spine also we can call it prickle cell layer. Because there are spine, we can also call it prickle cell layer. And this one is the thickest layer, guys. Thickest layer. This one is the thickest layer. Okay, and maximum amount of desmosomes are present here. So two things till now we have seen about stratum spinosum. Can you see here? This is your granulosum, so it will be having granule. This one is your spinosum. Okay, this one is your spinosum. So can you see these spine-like structures? These are your spine-like structures. Okay, so that is why it is known as stratum spinosum. And these spine-like structure, what? They are desmosome. They are basically desmosomes. Okay, so the most abundant cells will be desmosomes. Second thing you have to remember, second cell that we have already seen, that is your Langerhans cells. Langerhans cells are maximally present here. Okay, in the stratum spinosum. Two things you have to remember. कुछ नहीं याद हो रहा, दो चीजें याद रख लो. First thing, maximum desmosomes, maximum Langerhans cells are present in which layer? Stratum spinosum. Okay, in surgery you must have studied about a disease that is acanthosis nigricans, right? Acanthosis nigricans. Can you tell me what is acanthosis nigricans? And it will be having some kind of association with other things also. What is that acanthosis nigricans? Just try to understand. Spinosum, these layers are known as, these cells are known as acanth cells. Acanth मतलब क्या हो गया? These are spine-like cells. Okay, so acanthosis means what? There is nothing but that is thickening of stratum spinosum. Acanthosis, thickening of stratum spinosum. What is happening? Stratum spinosum will get thickened. This is known as acanthosis. And nigricans means what? It will be giving black color. Okay, it will be giving black color. Okay, it will be having desmosomes. Sir, what are the desmosomes? You have to remember, we are having desmoclin, we are having desmocolin, we are having desmoplakin, we are having placoglobins. Okay, placoglobins. So these are the cells that we are having. Okay, what is the function? It will be binding two keratinocytes together. This is the function of desmosomes. This is the function of desmosomes. Okay, next thing we are going to discuss about the stratum basal. Okay, stratum basal. What are the important features about stratum basal? This is also known as what? Which layer? क्या भी बोलते हैं इसको? What is the other name for this particular layer? Please try to answer, guys. What is the other name for this particular layer? Stratum basal. So the other name for this particular layer will be, very good Sneha, that is germinativum. Germinativum. This is the lowermost layer. Can you tell me what are the two cells that you have seen in stratum basal? This is your lowermost layer. Two cells that you have seen in this particular layer. That is your, first is your Merkel cell, second one is your melanocytes. Okay, what is that epidermal turnover time, guys? Epidermal turnover time. You know, there are some like snakes like organism. What they are doing? They are shedding of their skin. Likewise, we are also having shedding of the skin. Okay, हमारी भी जो skin होती है, that is also getting shed off. In how many days? What is the epidermal turnover time? If the question is asking, you have to answer in the between a range. You cannot say just like 56. So that would be in a range. And what is that range? Very good, Sneha, Koshalya. So that is the range. Range would be 52 to 75 days, or you can say in certain books it is written 8 weeks, guys. 8 weeks. Okay. Here we are having two things. Try to understand. We are having this stratum basal. Okay. The cells will be growing in the upward direction. It will be going to stratum corneum. Okay, it will take approximately 28 days, and this particular time period is known as epidermal transit time. This particular period is known as epidermal transit time. Remember, two different entities. One is epidermal turnover time, one is epidermal transit time. Okay. Then what will happen from this stratum corneum? It will be shedding off. It will be shed off to the environment, and that would be again taking how many days? That is 28 days. That would be again taking how many days, sir? 28 days. Done with this. Okay. Now we have what we have seen. Let's revise. We have seen from the outside we are having skin will be having three layers: epidermis, dermis, hypodermis, right? So we have already completed with the epidermis. We have seen 5 layers and from these 5 layers I've already told you the important question. These are also important question that they have asked you, right? Everything is important in this particular slide. Okay, maybe they will be covering 5 to 6 marks, but every mark is important, guys. Okay, so don't skip any subject, just watch this video, that would be good enough. Okay, and share with your friends also. Okay, so that is our stratum basal. Okay. Now we have seen all the layers: epidermis, dermis, hypodermis. Epidermis, we have seen 5 layers. That is from the come let's grab some burger, right? This is the mnemonic that we have already done. Now we will see some disorders. अभी क्या पढ़ेंगे? We will be discussing about some disorders, guys. Okay, कुछ disorders पढ़ेंगे. What are the disorders? First one is your parakeratosis. Sir, we have already discussed that the stratum corneum does not have any nucleus, right? Am I right? So if there is presence of nucleus, in stratum corneum, what do we call it? We call it parakeratosis. Okay, so what I have told you, sir, this is the stratum corneum. It is devoid of nucleus. There is no blue structure should be here, but if any kind of blue structure is here, that means there is a nucleus. And stratum corneum, if it is having some kind of a nucleus, that means it is parakeratosis. It is a disease. Okay, so what is that? Parakeratosis. What is the mnemonic? You can remember P's or PESA. Okay, whatever you want to remember, you can remember. P for psoriasis, E for eczema, A for actinic keratosis, S for seborrheic dermatitis, and lastly S for squamous cell carcinoma. Okay, so these are the conditions when you will be having what? You will be having nucleus present in stratum corneum. That means when you look under histopathological slide, you will take up the sample, you're looking under microscope, what you will be finding? You will be finding blue color structure. Okay, and that is the parakeratosis. Okay, second thing that we are having is dyskeratosis. What is the meaning of dyskeratosis? Dyskeratosis means what? Abnormal. Dys matlab kya hota? What is the meaning? Meaning of this will be abnormal keratinization. There will be abnormal deposition of the keratin. So what will be happening here? It will be happening in some benign diseases. Benign diseases like Hailey or Darier's disease. It will be happening in some benign diseases like Hailey and Darier's disease. Some pre-malignant diseases like Bowen's disease. Okay, and also can be seen in some malignant condition. Malignant means what? That is cancerous, right? That would be your squamous cell carcinoma. So these are certain situations where you will be finding this dyskeratotic cells. Okay, dyskeratosis cells. Okay, acanthocytes. What is the meaning, guys? Acanthosis, first thing we have already seen. What is the meaning of acanthosis? That is thickening of stratum spinosum. When stratum spinosum get thickened, that is known as acanthosis. Okay, acanth matlab kya hota hai? What is the meaning of acanth? Acanth is a spine like cell, and spine are the feature of which layer? That is stratum spinosum. Okay, acantholysis means what? Acantholysis, there will be separation of acantholysis. There will be separation of two keratinocytes. Okay, so there will be separation of keratinocytes. That is known as acantholysis. Guys, it is a bedside test that we are doing in our hospital. That is zinc smear. How we take the zinc smear? What we are doing, whatever lesions we are having, what we will be doing, we are just taking the scraping from the base. Okay, base में से scraping लेना है, and then we are putting some dyes over it, okay, some stains, and ultimately we are looking under microscope, okay, and then you will be finding this type of cells. These are what? These are separated keratinocytes. Why they are separated, sir? They are binded together with the help of this particular thing. What is that? That is desmosome. Now what is happening? Desmosome is not there, so what you will be finding? These separated cells, okay. So under zinc smear you will be finding these separated cells, okay. So that is nothing but your acantholysis, okay. What are the different conditions where you will be having antibodies against what? Okay, let's see. This is the most important table that that is coming across you. That is, first thing is your pemphigus vulgaris. Antibodies are formed against which desmosome? That is desmoglein 3, okay. Pemphigus foliaceus, desmoglein 1. Sir, how to remember? 1 is for F is for first, F is for 1. That is your first, right? So if they are talking about pemphigus foliaceus, your answer would be desmoglein 1 always, and they are asking question based on this, right? Okay, vulgaris is the most common, that would be your desmoglein 3. And paraneoplastic pemphigus, just remember P, desmoplakin or placoglobin. Just remember this P, desmoplakin or placoglobin, okay. And then we are having these benign diseases. These are due to calcium ATPase, okay. So this is the most important table from this particular slide. You have to remember this as it is, okay. Then we are having this micro abscess. Sir, what is the meaning of abscess? What is abscess? There are two things we will be discussing. One is pustule, and second one is your abscess. If there is a fluid filled lesion, there is a pus filled lesion which is small in size, we call it pustule. If this lesion is big in size, we call it abscess. So abscess is nothing but there is a pus filled lesion, okay. Pus filled lesion will be there. So what are these? Papillary tip microabscess. We have already seen. We have already seen. Remember whatever I have told you in basics, we will be utilizing that information. What is that? What is that thing? What is the part of epidermis that is going inside dermis? That is your rete ridges. And the part of dermis which is going into epidermis, that is known as dermal papilla, okay. So we are having papillary tip microabscess. That means something is getting accumulated here. Something is getting accumulated here. This is known as papillary tip microabscess. And this is particularly seen in which disease? Very good, that is seen in dermatitis herpetiformis. Wonderful group of students you are. Dermatitis herpetiformis, okay. Try to answer second one, herpetiformis. Second one, Munro's microabscess. I would be showing you image of everything, okay. So that would be seen in psoriasis, guys. Psoriasis mein milega, okay. Next one is your Kogos pustule. That is also we are going to see in psoriasis. I would be showing you the image, okay. Lastly, we are having Potrier's microabscess. Remember, guys, all these three microabscess are neutrophilic microabscess, okay. This one is your lymphocytic microabscess, that is Potrier's microabscess. It is seen in Mycosis fungoides. Can you see Mycosis fungoides? Which fungus is causing this particular thing? Can anyone answer? Which fungus is causing this particular thing? Mycosis fungoides. It's due to which fungus? No, sir, it is not due to fungus. It is due to it is a type of cancer, okay. It is a cutaneous T cell lymphoma. Very good. It is a cutaneous T cell lymphoma. It is not a fungal infection. It is a cancer, okay. It is a cancer. It will be having epidermal tropism, okay. It will be coming towards the skin, okay. Epidermis ki taraf badega, right. You will be studying this particular thing in pathology also. You will be having Sézary cells, cerebriform nucleus, all those things, right. So that is nothing but your Mycosis fungoides, showing you which kind of microabscess. That is your Potrier's microabscess, okay. यहाँ तक समझ में आया? Are you guys understanding? We are done with the epidermis part, okay. Now these are the important pointers that we have to remember, okay. Papillary tip microabscess, dermatitis herpetiformis, Munro's microabscess, and Kogos pustule. I would be showing you image. That would be psoriasis, okay. And then we are having Potrier's microabscess, that you will be finding in Mycosis fungoides, okay. Then coming on to next part is your basement membrane zone, okay. Uppermost layer will be, we are having skin, epidermis, then there will be basement membrane zone, then there will be dermis, then there will be hypodermis, okay. So in epidermis we have already seen all the structures, all the cells. Now we are discussing about the basement membrane zone, that is in between epidermis and dermis, right. So that we are talking about basement membrane zone. This is also known as dermo-epidermal junction. Okay, so now what kind of cells you will be finding here? Just try to understand, guys. These are your keratinocytes. These are your keratinocytes. If you understand these basics, every disease will be easy for you. Okay, so these are the keratinocytes. They are binded together with the help of what thing? With the help of desmosomes, right? Now these cells are binding to the basement membrane. These cells are binding to the basement with the help of what? This is your basement membrane, and they are binding with the help of a special protein that is known as hemidesmosome. Hemidesmosomes. Okay, they are binding with the help of hemidesmosomes. Look here, these are your cells. They are binding together with the help of desmosomes, but these cells are binding to the basement membrane. This is your basement membrane. Okay, and then there will be dermis. So these cells are binded with the help of hemidesmosomes. What are the hemidesmosomal protein that you have to remember? You can remember plectin, integrin, BPAG1, BPAG2. So most important, I will be writing for you, that is BPAG1, BPAG2, bullous pemphigoid antigen. You can remember like that. Okay, we are having integrin, we are having plectin. Okay, this we are also having like K5, K14. I would be telling you disorders. Okay, just remember BPAG1 is known as BP230. One है तो नाम बड़ा तो number भी बड़ा. What would be there? If it is 1, there will be more number. Second one is your BP180. It is also known as BP180. You can also write collagen 17. Okay, then we are having integrin and plectin. Okay, these are the important protein that you have to remember. Then there will be some other layers. This is your lamina lucida, then your lamina densa, and below densa that would be sublamina densa. Okay, below lamina densa would be sublamina densa, and ultimately we are having dermis. Okay, so these are the important layers. Okay, they have asked you a question, which one of them is the weakest layer? Your answer would be lamina lucida, also known as salt split layer. Okay, what are the disorders that can happen over here? First one is your bullous pemphigoid. Bullous pemphigoid, the meaning will be simple. Okay, bullous pemphigoid, what will happen in the bullous pemphigoid? You will be having antibodies against BPAG2 or BPAG1. Okay, you can be having antibodies against BPAG2 or BPAG1. Second one is your linear IgA disease. You will be having antibodies against most likely BPAG2. And third, we are having epidermolysis bullosa dystrophican, that would be having antibody against collagen 7. Okay, collagen 7. One more we have already seen, that is antibodies against K5 or 14, K5 or K14, keratin 5 or keratin 14. That would be considered as epidermolysis. Epidermolysis means what? Epidermis is getting lysed. Bullosa means there will be some kind of a fluid filled lesion. Bulla will be having clear fluid. Okay, bulla will be having clear fluid filled lesion. Bullosa. Simplex, your answer would be K5, K14. Okay, dystrophicains, if they are giving, your answer would be 7, collagen 7. Simplex, K5, K14. Okay, this is what you need to remember. Okay, we are done with this particular layer also. Now we are moving on to next layer. Next layer is your dermis. Okay, lowermost layer, second layer is your dermis. It will be having two layer. One is papillary dermis. This is your papillary dermis, and this is your reticular dermis. Try to understand. We have already seen all the layers, 5 layers we have already seen of the skin. We are having these granular layer, prickle cell layer, basal layer. Okay, then we are having this papillary dermis, then we are having reticular dermis, and ultimately we are having hypodermis. Okay, so what are the important points that you have to remember about this particular dermis? What are the most important cells in the dermis? What are these cells? Try to answer. What are the important cells dermis के अंदर क्या होंगे? These are your fibroblast. Okay, fibroblast are the most important cells of the dermis, right? Second most common question, that is most common type of collagen. Most common type of that is your type 1 collagen that you also see in the bones. Okay, type 1 will be seen in the bones, type 2 will be seen in the cartilage. Okay, cartilage. Second most common collagen that you will be finding here will be type 3 collagen. Okay, type 3 collagen. And what is the ratio? That would be 1:3. Okay, and one question they have asked you, what is the most common glycosamine that is happening here? That is your, okay, we can slow down. If you are not understanding, you can always ask me, or if I'm going too fast, you can always tell me, we can go a little bit slower. Okay, that is your most common glycosamine, that is your hyaluronic acid. Hyaluronic acid, remember guys, you guys are using hyaluronic acid on your skin also, right? What are the basic function of that hyaluronic acid that you are utilizing? Sir, it will be retaining, first thing, it will be retaining moisture. It will be retaining moisture. Okay, second thing, it will be increasing your blood flow. Okay, those girls who are having like that hyaluronic acid thing, that they already know. Okay, it will be increasing your blood flow, it will be increasing your moisture, it will be decreasing your wrinkles. Okay, basically it will be decreasing inflammation, right? It will be decreasing inflammation. Okay, anti-inflammatory is that, right? Some girls are already answering, right? They know more about it, right? So we are having this hyaluronic acid. Okay, hyaluronic acid. Okay, next thing about subcutaneous layer, we are also calling it hypodermis. Subcutaneous is also known as hypodermis. This is also known as panniculus. Panniculus, guys, panniculus. Okay, and if there is inflammation of panniculus, that is known as panniculitis. Panniculitis, and this is the question that they have asked you. What is panniculitis? Simple question they have asked you. What is panniculitis? Sir, panniculitis simple meaning will be, it will be inflammation of the hypodermis. Okay bache, that would be inflammation of the hypodermis. Okay, now please try to solve this question for me, then we will be revising everything, right? Please try to solve this particular question for me. Question number 1. Which layer of the skin is characterized by the presence of refractile granule? Everyone, please try to answer in the chat box. Please try to answer, guys. I'm getting C, spinosum. Some are telling lucidium. Okay. So, like, we are studying the mind of examiner, how they are asking questions to us, right? The examiner is asking question to us. Yes, if you already remember, that is fine. But in the exam, you know what happens? Your cortex will not work so efficiently. Okay, right now you have studied, that is why you are remembering. But in exam, you will be thinking like, sir, they are asking about some granules. I already know. In granulosum, there will be some kind of granules. Okay, I don't remember that is keratohyaline or odland bodies. I don't remember that, but I just remember some kind of granules I have studied. Okay, that is how your mind will be working in your examination, right? So we need to rule out the option. Every time you are solving a question, please try to rule out the option. Okay, so what you have studied in stratum corneum. Corneum, we have already known that it is devoid of nucleus. First thing that we have seen, it is devoid of nucleus. Let's revise. Second thing, in granulosum, we have seen two types of granules. One is keratohyaline granules. Second one is your odland bodies or lamellar bodies, right? So what is happening, if this keratohyaline granules are problematic, that means filamentous aggregating protein is problematic, that would be giving what? Filaggrin is defective, that would be giving what? Ichthyosis vulgaris. We have studied about ichthyosis vulgaris. Okay, odland bodies, they are defective, that means it will be giving some kind of eczema. We have already studied about winter eczema, right? Now stratum spinosum. Spinosum will be having two important cells. I have told you, one is desmosome, and second one is your Langerhans cells. Very very important, guys. Okay, Langerhans and desmosomes, they are talking about. Your answer will be stratum spinosum. Okay, lastly we are having lucidium. Remember guys, lucidium will be having refractile granules of eludin. So your answer would be D. Answer would be D. And this particular layer is present in palm and soles. Palm and soles. Okay, this is what you need to remember about this. Okay, try to answer this particular question. Question number 2. Preterm babies are born with thinner and less developed skin compared to full-term infants. Okay, which of the following is a characteristic feature associated with the skin of preterm babies? What would be your answer? Try to answer. C. How many say C? Sanjay, Sannyasi. Very good guys. So they want to know about preterm babies are born with thinner and less developed skin. We agree with that. Okay, to as compared to full term babies, which of the following is characteristic feature associated with the skin of preterm babies? So they want to know what is the characteristic feature. We already know, I'm getting all the answers, that is stratum corneum will be absent. Stratum corneum will be absent. But why basal cannot be the answer? Try to see here. Basal, we have seen how many cells? Two important cells. One is your melanocyte, that would be giving melanosome, that would be giving melanin color, right? That would be giving color, right? First thing, agar ye absent hoga, if this melanocyte will be absent, what will happen? That would be problematic situation. Second, Merkel cells are present in stratum basal. Okay, so we already know that this cannot be the answer. Okay, Merkel cells are touch receptor for crude touch. Okay, anterior spinothalamic pathway is the pathway, okay, from physiology. Next is your stratum granulosum. We have already seen stratum granulosum will be having these two things, odd length bodies, okay, keratohyaline granules. These two things we have already seen, so this cannot be the answer. Okay, stratum corneum, we already know corneum will not have nucleus, it will be devoid of nucleus, and if nucleus is present, that is known as parakeratosis. Okay. Then we are having stratum lucidium, guys. Okay, stratum lucidium we have already seen what kind of granules you will be finding. That is your refractile granules that is present in palm and sword. So are you guys understanding? Do let me know if you are understanding. Okay, what will happen to this particular baby, guys? This will be having no stratum corneum, that will lead to increase in heat loss, increase in water loss, guys, water loss. Okay, this baby is more prone to infection, this baby is more prone to infection. This baby can have multiple infections, right? So we need to take care of this particular baby, right? Now we will be discussing about the types of skin lesion. Okay, now we will be discussing about the types of skin lesion. What are the different types of skin lesions we are having? Are you guys understanding? Please try to answer in the chat box. Okay, we are having types of skin lesion. First one, we are having primary skin lesion, we are having secondary skin lesion. Sir, what is the difference between primary and secondary skin lesion? Primary skin lesions are those lesions which are primarily due to diseases. Okay, these are due to primary disease. For example, we are having acne, right? So that is due to primary disease. Okay, secondary skin lesions are those lesions which are due to inadequate treatment. Firstly, inadequate treatment, or secondly, it can be due to trauma. Okay, for example, we are having some kind of a nodule. Now what is happening? I'm not getting properly treated, or second thing, I am just scratching it or doing something with that. Okay, so that would be presenting as a trauma. Okay, so these are your secondary lesions. Let's see one by one and we will be understanding what are these lesions. We are having macule, we are having papule, nodule, tumor, plaque, wheal, vesicle, bulla, pustule. So all these things are your primary skin lesions. Okay, secondary skin lesions are your scales. We have already discussed what is scale. Then we are having crust, we are having fissure, we are having ulcer, we are having scar and atrophy also. Okay, so let's see one by one how they are differentiated, on the basis of what they are getting differentiated, on the basis of size they are getting differentiated. So first one that we are having is flat lesion. Okay, first one we are having is flat lesion. In flat lesion, if the size is less than 1 centimeter, we call it less than 1 centimeter flat lesion, we call it macule, guys. We call it macule. Try to answer if you know. I will be showing you images just after this. Try to remember now itself. 1 centimeter se kam ka lesion, if the lesion is lesser than 1 centimeter, that is known as macule. If it is more than 1 centimeter, we call it patch. We are talking about primary skin lesions first. Okay, if the material that is inside a lesion is clear fluid, and the lesion is less than 1 centimeter, that is your vesicle. That is what you are seeing in herpes. Herpes will be having vesicles, right? Multiple grouped vesicle. You will be finding what kind of fluid? Clear fluid. Okay, clear fluid hoga. Second thing, if the lesions are more bigger in size, I've told you about bulla. You will be studying about bullous pemphigoid. There are bullous atrophy, bullous things. Whenever you will talk about bulla means what? Sir, there is a clear fluid filled lesion which is more than 1 centimeter. Simple. Okay, next we are having solid lesions. Okay, solid lesions, if they are less than 1 centimeter, we call it papule. Okay, if they are bigger, more than 1 centimeter, we call it plaque. Okay, if they are going inside, they are going in the depth, we call it nodule. Okay, nodule. For example, we will discuss about nodulocystic acne. Okay, nodulocystic acne. Okay, so these are your solid lesions. Then we are having pus filled lesions. If they are small pus filled lesion, we call it pustule. If they are big lesions with a pus, that is known as abscess. That is known as abscess. That is known as abscess, guys. Okay, so we are having these type of lesions. We are having these type of lesions. Okay, these are different lesions. We will be differentiating based on the sizes. Okay, based on the sizes. Okay, then we are having wheals. What are wheals, sir? Wheals are basically itchy, erythematous and edematous lesions. Okay, itchy, there will be some kind of itching. Apart from that, they will be having some kind of erythema. Erythema means what? There will be red thing that you will be looking at. Okay, and there will be some kind of edema. Okay, edema will be there. Okay, next we are having petechias. Petechias you will be finding in like disorders, for example like dengue. Okay, in dengue also you will be having petechias. Okay, small hemorrhages will be there. Okay, so petechiae, they are less than 2 mm. Purpura, they are 2 to 5 mm. And ecchymosis, if it is more than 5 mm. Okay, they are based on the size we are differentiating. Okay, cyst, the meaning of cyst will be it is covered by epithelial cells. Okay, so let's see what we have seen. If there is a flat lesion, we call it macule. If it is more than 1 centimeter, we call it patch. If it is a clear fluid filled lesion less than 1 centimeter, that is vesicle. Agar bada hoga, if it is big, we call it bulla. If there is a solid lesion less than 0.5 or 1 centimeter, we call it papule. If it is more, we call it plaque. And if it is a solid lesion which is going into the depth, then we call it nodule. Okay, and then we are having small pus filled lesion, that is pustule, and big pus filled lesion are known as abscess. Okay, wheals is the characteristic feature of a disease that is known as urticaria. Okay, urticaria, the characteristic feature is wheal. You will be finding wheal where for example you are having some mosquito bite or bite via some ant. Okay, and then what will happen? You will be having some kind of itching, you will be having some kind of erythema, and there will be some kind of edema that you would be finding. Okay, these are your wheals. So try to see first let's cover the secondary lesions also. Okay, so what is the scale, guys? Scale, remember I've told you about scale. Scale is nothing but desquamation of stratum corneum. I've told you squamous cells will be moving apart. That is your scaling. Okay, second thing is your crust. What is a crust? Sir, crust is nothing but your dried up exudate. Okay, dried up exudate is crusting. You will be finding honey colored crusting. So what is that? Honey colored crusting you will be finding in impetigo. Bullous or non-bullous impetigo? Try to answer. Okay, so we are having crusting. You will be finding that crusting. That is your secondary lesions. Okay, erosions are basically loss of epidermis. So epidermis is gone, that is erosion. What is the excoriation? Linear erosion. You are having linear erosion because of nails or something, that is known as excoriation. Usko kya bolenge? We call it excoriation. Erosion, there will be loss of epidermis. Excoriation, there will be linear erosion. Okay, linear loss of epidermis. Lichenification, very important. It will be having some itchy lesions. Along with that, you will be finding thickening, and very important, you will be finding color change. Itchy lesion, thickening, color change. That would be your lichenification. Okay, next we are having is scar. Scar is a permanent fibrotic change. Okay, scar is a permanent fibrotic change. You will be finding keloid scar. You will be studying in surgery. For keloid prevention, what you are giving, try to answer in the chat box, guys. Okay. We are also having one more thing, that is your ulcer. That is your ulcer. What is ulcer, guys? Loss of epidermis plus dermis is known as ulcer. Loss of epidermis and dermis is known as ulcer. Let's see one by one and try to understand how these lesions are and how do we call it. Okay, so first of all, can you appreciate this fluid filled lesion? Okay, it is a clear fluid filled lesion which is more than 1 centimeter in size, that is known as bulla. Isko bulla bolenge, right? This is a flat lesion. This is a circular flat lesion, that is known as macule. Okay, if this flat lesion is big in size, we call it patch. Okay, if it is a small flat lesion, we call it macule. If it is a big flat lesion, we call it a patch. Okay, then we are having nodule. Nodule is a solid lesion which is going inside the depth. Okay, which is going in the depth. This is your papule less than 0.5 centimeter. That would be a superficial solid lesion, papule solid lesion. If it is more than 1 centimeter, we call it plaque. Okay, these are your pustules. They are having pus. If any lesion which is having pus less than 1 centimeter, that is your pustule. If it is big, we call it abscess. Okay, this is your vesicle. Vesicle is less than 1 centimeter. It will be having which kind of fluid? It will be having again clear fluid. Okay, clear fluid. This is what we have discussed, right? This is your wheals. Wheals are characteristic feature. You will be finding edema, erythema, and itching, right? This is your scales. Scales will be having what? Desquamation of stratum corneum. This is a stratum corneum, outermost layer of epidermis. It will be having desquamation. Crust, dried up exudate is known as crust. This is a linear crack known as fissure. Okay, this is your fissure. This is a excoriation. Excoriation is what? Basically loss of epidermis. Okay, linear loss of epidermis. Okay, that is due to nails. Okay, maybe due to nails, maybe due to thorn, maybe due to gravel rush. Okay, multiple things can happen, right? We are having erosion. Erosion is basically loss of epidermis, and I have told you what is ulcer. Ulcer is epidermis, loss of epidermis plus dermis is known as ulcer. This is your lichenification. You will be having thickening, you will be having itching, you will be having color change. Okay, and scar is ultimately the secondary scar. You will be finding there is a permanent damage. Okay, there is a permanent fibrotic change. Okay, you will be finding that. Okay, papule will be bigger. Papule will be smaller in size as compared to vesicle. Vesicle will be bigger enough, right? Vesicle will be having some kind of fluid inside, right? So these are the primary and secondary lesions. Okay, now let's talk about the Langer's lines, guys. Okay, these are some lines they are asking question on. So these are your Langer's lines. Okay, first thing, they are parallel to the collagen fibers. They are parallel to collagen fibers and perpendicular to muscle fibers. When you are going to your OT, okay, in your OT you will be finding these types of chart. Okay, these types of charts will be there, and they are used for incision for better healing. Okay, they are used for incision for better healing. These are your Langer's lines, not Langerhans. These are your Langer's lines. Okay, impetigo is there, but which impetigo, guys? Non-bullous. Okay, bullous impetigo is due to staph. We will be discussing about that. Okay, these are your Blaschko's lines. Try to look here. We are having this circular thing on over scalp. Circular thing you will be finding over scalp. That is your Blaschko's line. Okay, they are helpful in the identification. Basically, they are for the identification of embryonal migration of keratinocytes. So basically, keratinocytes are transferring in the body. Okay, so they will be telling us about the embryonal migration of keratinocytes. Not so important, but you have to remember the image. Okay, they are asking question based on the image. So whenever you are finding, just look at this particular head structure. If you are finding something circular, your answer will be Blaschko's line. Okay, Blaschko's line. What are the example? You will be finding these lines in these three particular things. First one is your incontinentia pigmenti, second is your hypomelanosis of Ito, and third one is your epidermal nevi. Okay, epidermal nevi. These three are important one. They have asked previously, they have asked question based on this. Okay, so these are the Blaschko's line. Next line we are having is your dermatome. Okay, dermatome is basically nerve distribution that you will be discussing about. For example, we will see multiple disease. For example, like we are having herpes zoster. Herpes zoster, also known as shingles. So what happens in the shingles? The meaning of herpes, just try to understand. I've told you the meaning of herpes will be grouped vesicle. And what is the meaning of zoster? Zoster का मतलब क्या होता है? The meaning of zoster will be along a nerve segment. The meaning of zoster will be along a nerve segment. So whenever you are looking for like herpes zoster, you will be having it along a nerve segment. For example, thoracic nerve segment is the most common. Okay, it can be happening like that. Okay, so that is the dermatomes. They are basically straight line. Dermatomes you can easily understand. They are basically straight lines. Okay, you can easily understand the dermatomes. Okay, so three lines you have to remember. One is Langer's lines. They are line of incision. They are also known as lines of tension. Okay, they are also known as lines of tension. Then we are having Blaschko's line, and then we are having, guys, dermatomes. Okay, dermatomes. So we are done with the chapter number 1. Are you guys understanding? Do let me know so that we can proceed to chapter number 2, that is about your skin appendages. Okay, अभी fast करेंगे skin appendages. We are having three things. We are having nails. In the skin appendages we have seen all the layers. Till now what we have seen epidermis, 5 layers of epidermis. Then we have seen dermoepidermal junction. There will be hemidesmosomal proteins. Then we have seen the dermis, papillary dermis, reticular dermis, important cells, all those things, collagen and all we have seen. Then we have discussed about the subcutaneous also. Then we have seen some disorders and secondary lesions also, primary and secondary lesions we have also covered. Now we are going to see skin appendages. What are skin appendages? Those structures which are attached to the skin. For example, we are having nails, we are having hairs, or we are having certain glands present in your bodies. Like, what are the glands that are present in your body? We are having nails, we are having hairs, we are having glands. Okay, we are having two types of gland. One is sebaceous gland, one is sweat gland. Okay, so we are having sebaceous gland, we are having sweat gland. Okay, very good, Umesh. Now let's see. Okay, we are having sebaceous and sweat gland. Sir, sebaceous gland will be secreting what? Sebum. Okay, it will be secreting sebum, and the function of sebum will be lubrication. Okay, lubrication. The function of sebum will be lubrication. Okay, so first of all, let's start with the nail itself. So nail pathology, let's see what are the different nail pathology that we have to see. So this is the normal structure of a nail. Okay, this part, that white part you are seeing, this is your lunula. Okay, this part is known as lateral nail fold. This is your lateral nail fold. This is known as proximal nail fold. Okay, this is this small skin that you are having over here around the lunula, that is known as cuticle or eponychium. Cuticle or eponychium. This is the basically body of nail. Okay, and these are the free edge of the nail and all these things. Okay, not so very important. Just remember this important part, that is lateral nail fold, that is proximal nail fold. Apart from that, this cuticle and lunula. Okay, now what is happening? We are having certain diseases present on nails. Okay, this is a normal nail. This is a normal nail. I have clubbed all the nail pathologies together. Okay, this is your pitting of the nail. Pitting means what is happening? Try to look. We are having some kind of depressions over here in the nail bed, right? That is your pitting. Onycholysis. Onycholysis means what? There will be separation of nail bed. There will be separation of nail from nail bed. Then we are having subungual hyperkeratosis. Hyperkeratosis. Hyper means increased. Keratosis means keratinization. Okay, so you will be having increased keratinization here. Increased deposition of keratin or increased keratinization. Okay, next one is your ridging. Okay, you can have ridging, you can have thickening, you can have crumbling, you can have certain color changes, but the most important out of them is your pitting. Okay, most important out of them is your pitting. We are having pitting. Pitting is the characteristic feature for two important diseases. One is alopecia areata, second one is your psoriasis. So in alopecia areata, just remember alopecia कहाँ होता है? Alopecia का मतलब क्या होता है? There will be loss of hair, so alopecia will be in the hair itself, right? So alopecia कहाँ होगा? Superficial. This is the pitting. Can you appreciate? This is pitting, this is pitting, this is pitting. Okay, so superficial pitting will be there. Or is it regular or irregular? Sir, there will be regular pitting. Okay, superficial regular pitting is a feature of alopecia areata. Very important keyword that you have to remember. Okay, second, psoriasis. In psoriasis, bacho, you will be seeing deep irregular pitting. Deep and irregular pitting. Deep and irregular pitting is the feature of psoriasis. Okay, so these two terminologies you have to remember. One is superficial regular pitting, second one is your deep irregular pitting. Okay, psoriasis mein you will be finding deep irregular pittings. Alopecia you will be having superficial regular pitting. Okay, you will be seeing these different nail pathology. First one is your clubbing. Clubbing is due to hypoxic conditions, guys. Hypoxic conditions. What can be the exception here? Hypoxic conditions, but due to, these are not due to COPD group of disorders. Okay, second one is your koilonychia. Koilonychia, the simple meaning will be spoon shaped nails. Okay, koilonychia will be spoon shaped nails. Okay, spoon shaped nails. Okay, these are seen in iron deficiency anemia and Plummer-Vinson syndrome. Can anyone tell me the triad of Plummer-Vinson syndrome? Please try to answer Plummer-Vinson syndrome. Okay, these are your Eldridge-Mees lines. These are your horizontal lines you will be finding in arsenic poisoning. Arsenic poisoning. This is your pterygium. In pterygium, what is happening? This is I've told you. This is proximal nail fold. Well, this proximal nail fold is tearing the nail apart into two parts. This is known as pterygium. This proximal nail fold is tearing the nail into two parts. That is known as pterygium, and pterygium is very very characteristic for lichen planus phase. Lichen planus के लिए characteristic feature क्या है? That is your pterygium. Okay, that is your pterygium. Okay, whenever they will be talking about pterygium, you have to remember about this lichen planus. Okay, iron deficiency anemia. What else, guys? Try to answer. What iron deficiency anemia will be there? That is already written. You will be having dysphagia, guys. Only few days left for examination. Please try to be more active. We are having iron deficiency anemia. Very good, Dr. RJ. That is iron deficiency anemia, esophageal varices, not varices. Esophageal webs will be there. Okay, esophageal webs will be there, and there will be iron deficiency anemia. So that is the triad that is important in your pathology as well, right? So we are clubbing different subjects. Okay, try to answer this one. What is happening? So this is your lateral nail fold. This is your lateral nail fold, and it is having some kind of pus, and this is known as paronychia. This is known as paronychia. There is infection of lateral nail fold, that is known as paronychia. Or the most common bacteria causing paronychia, that is your Staph aureus. Remember, guys, in complete dermatology, whenever I'm going to talk about any kind of acute infection is due to bacteria. Whenever I'm talking about any kind of chronic infection, that is due to fungus. So fungal infection will be chronic one. Okay, now let's differentiate between these two particular structures, half nail sign or teres nail. How you will differentiate? Both of them will be having half red nail. Okay, that is half nail will be having erythema. Okay, so how you will differentiate half nail sign or Lindsay's nail? You will be finding in chronic renal failure. Okay, that you will be finding in chronic renal failure. But try to appreciate these ground glass opacities, guys. These are your ground glass opacities, and this is a feature you will be finding in what? You will be finding in teres nail. Also teres nail you will be finding along with hepatic failure, guys. Hepatic failure may be teres nail milega. Ground glass opacity with teres nail, that is your hepatic failure or this thing. Okay, done. So now moving on to next is your very favorite of the examination. Examiner, they have asked this particular question multiple times. Okay, bache, try to answer this one. What is this particular thing that we are seeing here? What is this? This is known as oil drop sign, and it is a characteristic feature of which disease? This is the most characteristic lesion. Remember, guys, this is the most characteristic lesion. You will be finding in psoriasis, and this is your thimble nail or pitting that you are calling pitting. What kind of pitting, sir? Irregular pitting, and that is the most common feature. So two things about psoriasis you know now. First thing, most characteristic lesion is your oil drop sign, multiple times asked question. This is also known as salmon patch. Okay, these are your next one. These are your Bewes lines. Bewes lines are your depressed. These are your depressed. Look here, Bewes lines are your depressed. These are your depressed and growing lines. Okay, whereas these Moorcase lines, these are your non-depressed and non-growing lines. Okay, both of them are feature of which diseases? They are feature of chronic illnesses. They are present in chronic illnesses. Okay, and this one is your distorted nail. Can you appreciate? This is a distorted nail, and this is also known as ram's horns nails. Okay, this is basically a distorted nail. Basically a distorted nail that you are finding over here. Okay, so these are the some nail pathology that I have clubbed together. So please try to watch this pictures again. Okay, so what we have seen clubbing, we have seen koilonychia, Eldridge Meesland, pterygium, right? We have seen paronychia. They have asked you questions on paronychia. Okay, we have seen half nail sign. We have also seen Terry's nail. We have seen Salmon patch pitting. Salmon patch is the most characteristic lesion. Pitting is the most common lesion of psoriasis. Okay, next we are having Bewes lines, Muircase lines, and onychogryphosis. Okay, now moving on to second gland. Second gland is your hair follicle. Hair follicle. We are having three stages of hair follicle. One is your anagen, second one is your catagen, third one is your telogen. Sir, anagen will be lasting for how many days or years or weeks? That would be lasting for years. Catagen would be lasting for weeks, and telogen would be lasting for months. Okay, so if there is increased hair loss, what do we call it? Increased hair loss. We call it hair loss. What do we call hair loss? If there is hair loss, we call it alopecia. Alopecia, right? So let's discuss about alopecia. They are asking question based on alopecia. We are having different types of alopecia. We are having different types of alopecia. First, you have to remember we are having cicatricial alopecia and non-cicatricial alopecia. Okay, cicatricial or non-cicatricial, what is that? We are having scarring type or non-scarring type. मतलब क्या होगा scarring type or non-scarring type? Try to understand this. If we are having scarring type of alopecia, that means once the hair loss is there, that is a permanent change. Nothing will happen again. Your hairs will be gone. That is gone, right? Non-scarring type will be having there is a chance of regaining of the hair. Okay, so what are the mnemonic for non-scarring type and what is mnemonic for scarring type? Let's see what are the condition when you are finding non-scarring type of alopecia. This is also known as non-cicatricial type of alopecia. Okay, so first thing is your tinea capitis. Tinea is basically what? Let me give you information. Tinea is a basically superficial fungal infection, right? Superficial fungal infection. So we are having two types of tinea, guys. One is inflammatory type, another one is non-inflammatory type. Okay, inflammatory type we are having carrion and favus. Okay, carrion and favus. You will be studying about painful bogey swelling on the head, that is carrion. You will be having dense crusting, scutula, that is your inflammatory type. Okay, non-inflammatory type will be having gray patch. You will be having like your black dots. Okay, so that would be your tinea capitis. Second is your hormonal, because of hormone, that can be due to hypothyroidism, that can be due to androgenic alopecia. Okay, these are your non-scarring type of alopecia. We are having anagen effluvium. Anagen effluvium, talking about chemotherapy. Alopecia areata, which is autoimmune condition. You will be having a hair loss from a particular part, but you can get those hair back, right? Next is your trichotillomania. Tricho matlab hair, tilo means pulling, and mania is a psychiatric condition. So that is your trichotillomania. Patient will be pulling their own hairs, right? Secondary syphilis, also known as moth-eaten syphilis, we will be finding in secondary syphilis. What is the lesion you will be finding? These are your condyloma latas. Okay, in primary syphilis you will be having chancre, in secondary condyloma lata, in tertiary syphilis you will be having gammas, that is basically granulomas. Okay, SLE will be showing you non-scarring type of alopecia. Telogen effluvium will be telogen effluvium means what? There will be some kind of hair loss. Okay, after some diseases you will be finding some kind of history of a disease. Yes, you can watch it, anyone can watch it. I am teaching with the basics. Okay, so you can learn new things. Okay, second we are having a scarring type of alopecia. That means once the hair loss is there, those hairs cannot grow back, right? So we are having this type of alopecia in scleroderma. Second, inflammatory type of tinea capitis. Third, we are having folliculitis. DLE, remember DLE will be causing scarring type of alopecia. Lupus vulgaris, which is the most common type of cutaneous TB. Remember, in dermatology, vulgaris means most common. So lupus vulgaris is the most common type of cutaneous TB. And last, we are having lichen planopilaris. Okay, so these are the important causes. This is the important table that you have to remember. That is the mnemonic that you have to see. Okay, now let's see one by one about different types of different types of hair losses. Okay, now let's see about different type of hair losses. We are having, first one is your androgenic alopecia. Androgenic alopecia, we are having two types of hair loss, one in the males. In the males, the hair will be going from this particular region or from there, right, from the vertex or from the here, right. So that is known as Norwood Hamilton grading. This type of grading system that we are using for men, that is known as Norwood Hamilton grading. Okay, in females we are having two pattern. One is Ludwig pattern, second one is Olsen pattern. Okay, in Ludwig patterns, the female will be having hair loss from frontal or vertex region. Okay, in Olsen, the female will be hair loss from the parts from where she is parting their hair. Okay, so where from the part she is parting their hair, she will be having hair loss from that particular area. So that is Olsen and Ludwig. Okay, how do you treat this particular situation? Please try to answer the drug. These are androgenic alopecias due to androgen. So what are the androgens that are causing it, right? What are the androgens, guys? What are the androgens that are causing it? And how do you stop those androgens, right? That is, testosterone is converting into dihydrotestosterone. How you can stop that? We can use a drug that is 5-alpha reductase inhibitor. You already know the answer. Please try to answer. That is your finasteride. But the first line drug that we are using is minoxidil. Is a potassium channel opener. Minoxidil. Okay, minoxidil you can use 2% in the females and you can use 5% in the males. Okay, 5% in the males. So that is the treatment for androgenic alopecia. Second one that is coming up is your alopecia areata. Okay, samajh mein aaya? First one we are done with that. Second one we are having is alopecia areata. Alopecia areata will be having what? Alopecia areata will be having particular area which will be having hair loss. Particular area will be having hair loss, guys. Particular area will be having the hair loss. Okay. For example, look here. What are the clinical important features that you need to remember over here? It is a autoimmune condition. First thing, it is a autoimmune condition. What do you know about this alopecia areata? Multiple questions has been asked from this. You have to mug up this, right? You will be finding easily pluckable hair. Whatever important points, keywords I am giving you, easily pluckable hairs will be there. Okay, exclamation mark sign you will be finding when you are removing that hair. You will be having exclamation mark sign. Okay, that would be giving you this type of appearance, and around that mark sign you will be having that perifollicular, this perifollicular infiltration. This perifollicular infiltration will be present over there, and this is known as, this is giving a particular appearance, and this is known as, please try to answer, this is known as swarm of bee appearance. Very important, guys. Swarm of bee appearance. This is known as swarm of bee appearance. One more important thing that you have to remember about this, Vache, that is it will be sparing the gray hairs. It will be sparing the gray hairs, and this is we don't know the exact mechanism for that, but it is not affecting the gray hairs. Okay, and one more thing that we have already discussed, you will be finding pitting. You will be finding pitting. What kind of pitting? Remember, I've talked about superficial thing. Okay, so that would be superficial. Irregular or regular? Here you will be finding regular pitting. Okay, regular pitting. So that would be superficial regular pitting. So these are the important points that you have to remember about alopecia areata. Very important thing, guys. Multiple times question asked from this particular slide, right? So you have to remember this. Okay, again we will be revising. It is an autoimmune condition. Easily pluckable hairs you will be finding. Exclamation mark sign. Around that exclamation mark sign you will be having swarm of bee appearance, which is basically perifollicular infiltrations. Okay, gray hairs will be spared here, and the pitting will be superficial and regular. Okay, these are the most important point that you have to remember about this particular thing. Okay, now let's talk about anagen effluvium. Anagen effluvium, where you are finding, in which patients you will be finding anagen effluvium? You will be finding this particular thing in cancer patient, guys. Cancer patients. So cancer patients will be having chemotherapy. All the chemotherapeutic agents, whatever drugs that we are using, what these drugs will be doing, ये drugs क्या करती है? They will be killing all mitotically active cells. Okay, whatever cells are rapidly dividing in your body, they will be killing those cells, right? So for example, your bone marrow will be having rapid division. so it will be causing bone marrow suppression. Okay, your hairs are rapidly dividing in the anagen phase, right? So it will be killing those cells. That is why you are having that anagen effluvium, that is known as loss of hairs. Okay, after like 15 to 20 days of chemotherapy, you will be having those hair loss. Okay, and that is from the anagen phase. Okay, telogen effluvium, how you will identify? The patient will be coming to you with history. In question you will be having some kind of a history, guys, and in that history, remember, in that history what they will be written, the patient is having some kind of a disease few days back, okay, few months back, because we already know telogen will be lasting for a few weeks. Okay, telogen will be lasting for a few weeks, so you will be having history of like few months. Okay, you will be having few months history. Patient can be having like multiple disease. Patient can be a pregnant female, she can come to you, pregnant female. Patient can tell us about like she had a typhoid. Okay, they can have a history of COVID-19. So all these things, whenever you are finding a history, just think in terms of telogen effluvium. Whenever you are finding a history, just go and think in terms of telogen effluvium. Next we are having is trichotillomania. Tricho means hair, telo means pulling, and mania is a psychiatric condition. So how you will treat this particular condition? Here what is happening, you will be having a patient who is getting satisfied just by pulling his or her hairs, right? So pulling of hairs you will be seeing. And how you will treat this particular situation? You will be giving, first thing you can give CBT, that is cognitive behavioral therapy. Another, you can use SSRI drug. Okay, and what is the peculiar thing you will be finding here? Because of that constant pulling, what will happen? There will be perifollicular hemorrhages. Perifollicular hemorrhages that you can see. Okay, so these are the important points about this trichotillomania, right? Okay, next one is your traction alopecia. Those people who are using like bands on the head, those people who are having like pony. Okay, so what they are doing, those people who are keeping their ponies very tight, what will happen there? Because of that constant traction, okay, because of that constant pressure, what will happen? You will be having that hair loss. Okay, you will be having that hair loss because of constant traction or pressure. That is known as traction alopecia. That is known as traction alopecia. Okay, are you guys understanding? Yeah, hawa mein ja raha hai sab. Okay, we will be revising. Okay, so what we have seen in the alopecia part, we have seen alopecia is divided into two parts. We are having scarring type, non-scarring type. We have already seen all the causes, guys. This is very, very important. NEET PG, they have asked 2-3 questions from this particular slide. You know, NEET PG and FMG are taken by the same board, so you have to solve all the questions. They are having the similar question bank, right? So you have to remember this. Okay, they can come up in your FMG examinations also. Okay, pattern hair loss, androgenic alopecia. Male pattern we have seen Hamilton. Female pattern we are having Ludwig and Olsen, right? Treatment I have already told you. Alopecia areata, autoimmune condition. Perifollicular hemorrhage, very, very important. Okay, you will be having swarm of bee appearance, exclamation mark sign. Pitting will be superficial, regular. In psoriasis, pitting will be deep and irregular. Okay, next we are having anagen effluvium. Always think in terms of cancer patient. Telogen, always thinks about the history that is given. Trichotillomania, psychiatric condition. Traction alopecia, we are all set, right? Now let's talk about the sweat glands. Okay, now we will be discussing about the glands. We are having two glands. Okay, one is sweat gland, second one is your sebaceous gland. Okay, sweat gland, we are having two types of sweat gland. One is eccrine, second one is your apocrine. Eccrine में क्या होगा बच्चों? E for just remember, it will be present everywhere. It will be present everywhere on the body, right? Sweat glands are present everywhere. Maximum sweat glands are present where? On your palm or soles? Which one will be having more amount of sweat glands? Okay, first of all, they are present in palm and soles, but which one is having more, right? Try to answer. Just remember C4, they are under cholinergic control. They are under cholinergic control. Cholinergic matlab, the meaning of cholinergic will be, it will be under parasympathetic control. It will be under acetylcholine control, right? Apo means A for apo, A for apo. The meaning will be, the meaning of apo will be alone. Always whenever there is apo, like in biochemistry you study like apo B48 Okay, apoenzymes. So basically they are always apo terminology. The simple meaning will be along. Along what, sir? It will be opening along a hair follicle. So where you are having hair follicle, like in your armpits, okay, axilla, okay, in your groin region, you will be having which kind of glands? You will be having, sir, apocrine glands. They are under which control? A for adrenergic control. They are under adrenergic control. That means they are under sympathetic control. Okay. Now what you have to remember, if there is inflammation of these eccrine glands, you know, in summer what will happen? You are going outside, standing outside for longer period of time. You know what happens? You will be having inflammation of these glands, and that is a disease known as prickly heat or malaria. That is a disease known as prickly heat or malaria. What will happen in that? Look here, guys. Please try to understand this. In Hindi, what do we call it? We call it ghamoria, right? You will be having, there is inflammation of these eccrine sweat glands. Okay, you will be having inflammation of these eccrine sweat glands. Okay, okay, bache. Now let's talk about this particular thing, apocrine glands. Okay, if there is inflammation of this apocrine glands, there will be a disease known as Fox-Fordyce's disease. Okay, just remember the history. I have told you apocrine. Apocrine means what? They will be opening around some part where are hair follicles. So you will be given an image of axilla, or you will be given a history along with the hair follicle. Okay, so your answer would be Fox-Fordyce's disease. Okay, just remember Fox-Fordyce's disease is a inflammation of apocrine gland, and this one malaria is inflammation of eccrine gland. Okay, these two are done. Okay, now let's talk about the sebaceous glands. Sebaceous glands will be releasing what, sir? We have already discussed. It will be releasing sebum, and sebum is responsible for what? Sebum is responsible for lubrication. Do you know how acne are forming on? Do you know how acne are forming? Just look here, you will be understanding. So this is your gland. This is your sebaceous gland. Okay, sebaceous gland. What it will be making, sir? It will be making some sebum, and that sebum will be coming around the hair follicle. Now what is happening? Try to understand this. Give your concentration for 5 minutes and you will be understanding what is happening. Now what is happening? The most common lesion, or the most characteristic lesion that you are finding, most characteristic lesion of acne is, try to answer this question, most characteristic lesion in acne, they are your comedones. Okay, and what are these comedones? We are having, sir, white heads, we are having black heads, right? You already know what is a white head, what is a black head. So what is happening? Try to understand, sir. This sebum is coming out continuously. Okay, this sebum is coming out continuously. Now what is happening? If there is a blockage, what will happen? This sebum will not come out. This sebum will accumulate here itself, right? If there is a blockage, and there is a blockage, this is known as whitehead. Because it is closed, there will be formation of a whitehead. If there is no blockage, it is coming out and it will be coming with contact with the environment. What will happen? There will be some kind of a reaction with the environment. This sebum will be reacting with the environment and giving an appearance that is known as blackhead. So blackhead or whitehead, समझ में आया? What is whitehead? Whitehead means what, sir? This opening is getting closed. Okay, because this opening is getting closed and inside will be sebum, so that would be giving a white appearance. That is your whitehead. Okay, and what is blackhead? This one will be reacting with the environment and giving you, environment में क्या होता है? What are different things? We are having oxygen, carbon dioxide, multiple gases are there, so it will be reacting and making it a blackhead. Now you understand what is blackhead, what is a whitehead. Now try to understand, whenever there is accumulation of something for a longer period of time, for example, the sebum will be accumulated here, right? Sebum will be accumulated here. What will happen? It will be having some kind of bacterial party, right? Bacteria will be coming. If bacteria will be coming, sir, what will happen? There will be some kind of infection, right? And what is the most common bacteria that is causing acne? And this is known as acne, right? What will happen here? You will be having acne. Okay, because of this clogged pores, what will happen? There will be formation of acne. And how we are going to treat acne? You already know the drug of choice, or the treatment of choice for acne will be, what is that, sir? How you are treating acne? Try to answer. With the help of which drugs you are treating acne? You are treating acne with isotretinoin, retinoids. So basically all these vitamin A derivatives doing what? they will be causing dryness. Those people who are using these drugs, they already know they will be causing dryness, and because of that dryness, what will happen? The sebum will be dried up, right? Every bacteria will be dead, sebum will be dried up. Bacteria will be dead via your face wash that you are using. It will be having some salicylic acid. The pH of the skin will be always acidic. Okay, the pH of the skin will be acidic, so that is why we are using acidic face cleansers and all those things. Okay, so basically this is about the acne. Acne is basically, that is the, I will be telling you about the doses also. Okay, if you want, you can ask. Okay, so we are having pilosebaceous unit. Pilosebaceous unit, if there is inflammation of pilosebaceous unit, that is known as acne. That is known as acne. And what is the most common bacteria causing acne? That is nothing but your propionibacterium acne. Propionibacterium acne, or you can call it P acne. Okay, P acne. This is the photiasis spores. You know what happens? These sebaceous glands, whenever these sebaceous glands are present on ectopic place. Ectopic का मतलब क्या होता है? The meaning of ectopic means, the simple meaning, they are not present on their original site, they are present on different site. Okay, so these are the ectopic sweat glands, and this is known as photiasis spores. This is known as photiasis spores. Okay, this is known as photiasis spores. Okay guys, now we will be discussing about the different kind of acne. Okay, we are having mild to moderate, we are having mild acne. For mild acne, like the most characteristic or most common lesion will be comedones. We are having open comedone, we are having closed comedone. Okay, so open will be black, closed will be white. Okay, we are having, we can use for mild to moderate cases, we can use drugs like adapalene. Okay, we can use retinol, adapalene. Okay, for for moderate acne, we can use topical retinoids. Along with that, what we can do, हम लोग क्या करेंगे, टॉपिकल एंटीबायोटिक्स भी दे देंगे, राइट. Next, we are having moderate to less severe, then we are giving retinoids, then we are giving antibiotics. Along with that, we can add benzyl peroxide, and lastly, if they are having nodulocystic acne, that means they are going deep in the skin, what we can do is we can give isotretinoin. Okay, isotretinoin, whenever you are giving isotretinoin, you need to have a proper history of the patient. You need to know whether the patient is going to conceive in future or not. Okay, because this is a teratogenic drug. Okay, so first of all, the patient is coming to you, she or he is having some comedones. You can treat comedones. You can use normal adapalene or retinol creams. Okay, then if it is not treated with these retinol creams or adapalene, then you can give topical antibiotics. Which antibiotics you are using? In acne, you are using clindamycin. Okay, clindamycin, you can give the ointment of clindamycin. Then what you can do, if it is also not treated by this one, then we can use topical retinoid. We can give antibiotics, but along with that, we can also use benzyl peroxide. And ultimately, if they are not treated with anything, then ultimately we will be using what, sir? We will be using isotretinoin. Okay, so this is about the treatment. Okay, so please try to answer this question. First line of treatment for acne and comedone should be, what should be the treatment, guys? First line, these are the questions they have asked you. Try to answer first one, and then try to read the question number 2 also. Very good. Sneha, Sia, Azan, others are, please try to answer. Please try to be interactive. No one is going to judge you right now, right? If you are making mistakes here in the class, you are not going to make those mistakes in the examination hall. Okay, so please try to speak. So first line of treatment for acne and comedones should be topical retinoids, guys. We cannot use steroids. Antibiotics also we are not utilizing in the first case. Nowadays, there is some guidelines which is coming from NMC a few days back, day before yesterday. They are telling we cannot use antibiotics without diagnosis. Okay, we should not use antibiotics without diagnosis. First of all, we need to make diagnosis, then we are giving antibiotics. Earlier, what we are doing, we are giving empirical antibiotics. For example, patient is coming to me, I don't know what can be the situation. So what I am giving a broad spectrum antibiotics, 3rd generation cephalosporin. But nowadays the government has given the guidelines. Okay, next, benzyl peroxide, we will be using less severe acne. Okay, less category 3rd acne we will be using. Okay, so answer here would be topical retinoids like retinol or adapalene. Okay, next, try to answer this question. Second ka D. You guys are answering very good. Azan, Sia. So that is a nail infection. What is the question? What is the probable diagnosis for a 40-year-old woman experiencing pain in her fingernail? There is a presence of pus on the nail, right? So when you are looking at this particular situation, try to see what is happening here. There is infection of proximal nail fold or lateral nail fold. Okay, so basically in the side of the nail there is some kind of infection. The most common causative agent would be Staph aureus, so the drug that you will be using will be amoxicillin. Okay, amoxicillin you can use. Apart from that, there is infection, and that is known as paronychia. Okay, that is known as paronychia. Okay, next question, try to answer this one. A patient presented with multiple nodulocystic lesions. Okay, if they are not giving you image but they are giving you the keywords, you have to identify the keywords. Okay, nodulocystic is a grade 4 acne. Okay, nodulocystic, there are cysts, there are nodules, right? So that is a grade 4 acne. And for grade 4, what is the drug that you will be utilizing? Try to answer, guys. Very good, Sannyasi Pandit, Sneha, very good, bachcho. So that would be Sad. That would be your isotretinoin, guys. Very good, Sad. So that would be your isotretinoin. We cannot use steroids, guys. Here we cannot use steroids. Second, erythromycin and tetracycline, both of them are antibiotic. The ultimate drug of choice for nodulocystic acne would be your isotretinoin. Okay, so these type of questions are coming in your examination, and I really hope you are able to answer this type of question. Okay, so next one is your papillosquamous disorder. First one is your psoriasis, guys. Very, very important. Psoriasis is an autoimmune disorder. What is the most common site and what is the most common type? Please try to answer. What is the most common site? Sir, most common site will be extensor surface. Your extensor surface of the body, like your extensor surface of your body, you will be having this type of lesions. Okay, so that is your extensor surface. Most common type, no need to worry, that is your psoriasis vulgaris. Wherever you will be studying about most common something, answer would be vulgaris in this dermatology. Okay, dermatology is short, sweet subject, right? So psoriasis vulgaris, you can score 100% here, right? You can easily score 100%. Okay, so what is the mnemonic that you have to remember for psoriasis? That is your polish, guys. Polish. P for, here you will be finding P for pitting, O for oil drop sign, O for oil drop sign will be there. L for O and L will go together. Okay, this O and L will go together. That is your onycholysis. I will be telling you everything. Okay, just be patient. Onycholysis. I for irregular, pitting will be irregular. S and H will be subungual hyperkeratosis. Subungual hyperkeratosis. So this is the mnemonic. This is polish. Polish is the mnemonic for that. So you will be finding these are the peculiar features that you will be finding in psoriasis. Okay, pitting will be there. Oil drop sign will be there. L for onycholysis. OL will be onycholysis. I for irregular pitting will be there. And S and H will be subungual hyperkeratosis. Okay, so let's see what are these things that I am talking about. This one is your pitting, and this one is which type of pitting we have already seen in polish, that is irregular pitting of nails will be seen. And this is a most common feature, most characteristic feature is your this one, guys. Most characteristic feature is your this one. One question is expected from this particular slide. This is the most characteristic feature, that is known as Salmon patch. Last year exam they have given this question with the image, that is your Salmon patch. Okay, this is your onycholysis. Onycholysis, the meaning will be simple. Onycho means nail, lysis means there will be broken down of nails. Okay, what is this particular thing? This is your silvery white scales. Okay, silver white scales. Can you appreciate? These are silvery white scales. Okay, and there is a membrane, there is a ring around it. Okay, there is a ring around it, and this ring is known as Warnhoff ring. This ring is known as Warnhoff ring. Okay, and there will be a membrane around above it, that is known as Buckley's membrane. That is known as Buckley's membrane. And when you are trying to remove that Buckley's membrane, you know what happened? There will be some pinpoint bleeding. there will be some pinpoint bleeding, and this pinpoint bleeding is known as which sign? Auspit sign. Okay, auspit sign. So try to recap everything. Let's see one by one what are the things that are happening here. So we are having psoriasis. Psoriasis is an autoimmune disorder. Second thing, most common site will be extensor surface. Third thing, most common type of psoriasis will be psoriasis vulgaris. What you have to remember, the mnemonic. Mnemonic is polish. P for pitting, O for onychol, O for oil drop sign. Oil drop sign is also known as salmon patch. Next, L for, that is onycholysis. You will be having this type of nail deformities. Okay, distorted nail you will be finding. I for irregular pitting will be there. S and H will be subungual hyperkeratosis. You cannot make any questions wrong from this particular slide. Okay. Next thing is you will be having these type of silvery white lesions, and around that lesion you will be having a ring that is known as Bornoff ring. Okay, above the lesion you will be having a membrane that is known as Berkeley's membrane, and when you try to remove that particular membrane, you know what happens? There will be some bleeding occur. Okay, some pinpoint hemorrhages will be there, and this is known as pinpoint hemorrhages. This is known as which sign? Auspit sign. इसको कौन सा sign बोलेंगे? Auspit sign बोलेंगे. Okay. Next, try to look here in histopathology slide. Okay, in histopathology finding, what are the things we have to remember? First of all, can you appreciate these blue dots? Remember, I have told you in the first slide itself, corneum should not be having any blue structures. Okay, stratum corneum is devoid of nucleus, but you can appreciate these blue dots, and these are what, sir? Nucleus. These are nucleus, and if there is nucleus present in stratum corneum, we call it parakeratosis. Okay, parakeratosis. First thing done. Second thing, we are having this type of abscess, right? Abscess is what? Basically we have seen Munro's microabscess that is present in stratum corneum. That is basically accumulation of neutrophils. So accumulation of pus or neutrophils. Okay. Second, we are having this pustule, spongiform Kogo's pustule. Okay, two things I have told you, Munro microabscess and Kogo's pustule. They are feature of psoriasis. Okay, so this is your Kogo's pustule finding in spinous or granular layer. Okay, apart from that, I have told you the part of epidermis which is going into dermis. This is the part of epidermis which is going into dermis. This is known as rete ridges. Okay, so here you can appreciate long rete ridges. Okay, long club shaped rete ridges you are finding. Okay, so these are the particular findings on the basis of which we are identifying that the patient is having psoriasis. Okay, this is for the diagnosis purpose also. Okay, so these are the important point that you have to remember. Parakeratosis, इतना याद कर लिया, क्वेश्चन कहीं भी गलत नहीं होगा. We are having parakeratosis, we are having Munro's microabscess, we are having Kogo's pustule, and we are having club shaped rete ridges. 4 points you have to remember. Munro microabscess, okay, Kogo's pustule. Okay, next is elongated rete ridges, long rete ridges, and lastly we are having parakeratosis. Important stuff. Please remember this information and your questions will be easy for you. Okay, now let's see different kind of psoriasis before moving on to lichen planus. So this is the last slide. We will be discussing about the treatment. Okay, first of all, what is this type of psoriasis that you are looking? Can you appreciate these pus filled lesions? What I have told you, these are your pus, right? Along with the pus there is some kind of a scaling you are finding. So this is known as pustular psoriasis. Anyone please try to answer what is the drug of choice for pustular psoriasis? There will be scaling and there will be pus. Drug of choice for pustular psoriasis, previous year question. Okay, I have told you the psoriasis will be present on your extensor surface, but here can you appreciate this psoriasis is present in your flexor surface, right? So this is known as flexor psoriasis, flexural, or also known as inverse psoriasis, and the drug of choice for inverse psoriasis will be methotrexate. So methotrexate. Okay, very good, Sneha. The drug of choice for pustular psoriasis will be acitretin, and the drug of choice for inverse psoriasis will be methotrexate. Okay, this is the psoriasis you are finding in pregnancy. You will be having multiple lesions, that is known as impetigo herpetiformis, which is basically psoriasis in pregnancy. Can you use methotrexate? No sir, we cannot use. So you will be giving steroids, or you can use cyclosporine. Okay, you can use steroids or cyclosporine. This is your red color structure that you are looking at, that is your erythrodermic psoriasis, and the drug of choice will be methotrexate. Okay, Can you appreciate these gutter-like structure? These gutter-like structures, that is known as gutted psoriasis. Okay, you will be having some upper respiratory tract infection, and then you will be having this type of psoriasis. Okay, very very important. The examiner will be asking you what can be the drug of choice. He will be giving you four options. क्या देगा option? He will be giving you acetretin, he will be giving you methotrexate, he will be giving you steroids, and then he will be giving you antibiotics. You will not think in term of antibiotics, but the drug of choice for gutted psoriasis will be antibiotics, because it is after a respiratory tract infection. So gutted psoriasis में drug of choice क्या होगा? Antibiotics होगा, and this can be a potentially asked question. Okay, you have to remember this. For scalp psoriasis, we can use steroids. Okay, we can use steroids. Okay, so these are the different types of psoriasis you have to remember, and the most important points I have already told you about the psoriasis. Now coming on to next disease is your lichen planus. Next disease is your lichen planus. Lichen planus, we have to remember, first thing we already know about lichen planus, that is pterygium. Basically this proximal nail fold, remember guys, this proximal nail fold is dividing the nails into two parts. Okay, what else you will be finding? It is also known as 5P disease. This is also known as 5P disease. Why do we call it 5P disease? The reason being, you will be having plain, you will be having 5P, you will be having plain, purple, polygonal. These are the keywords you will be finding in exam. Plain, purple, polygonal, pruritic. Pruritic means with itching. Pruritic, papules. You will be having solid lesions, that is a papule. So you will be having this type of plain, purple, flat top, polygonal papules. Okay, so you have to look for this 5P. Purple, they can also write like violaceous. Okay, sometimes they can write violaceous papules. Okay, along with that you will be having mucosal involvement. Okay, just look for the mucosal involvement, and mucosal involvement you will be finding in the question. Just look for the keywords. If they are giving white reticular lacy pattern, the keyword is white reticular lacy pattern. If it is present, that would be your Wickham's tria, which is a feature you will be finding in lichen planus. Three things you have to remember: plain, purple, polygonal, pruritic papules. Okay, second thing, pterygium, and lastly we are having Wickham's tria. These are the important points. Now look on the HPE slide, histopathological slide. What you are going to see, you are going to see hyperkeratosis, that is abnormal deposition of keratin. Second, the most important thing is your sawtooth rete-ridges. Okay, just look here, you will be having these sawtooth rete-ridges. These rete-ridges are going just like a sawtooth. These are sawtooth rete-ridges, and this is a feature of lichen planus. Okay, lichen planus. Apart from that, two important things: one is Max Joseph cleft and C-weight bodies. Okay, so here you have to remember Max Joseph space or C-weight bodies. Okay, and sawtooth rete-ridges. Sawtooth rete-ridges. Your answer will be always in the terms of lichen planus. Okay, this is what you need to remember. If you remember this much information: pterygium, Wickham's tria, plain, purple, polygonal, pruritic papules, Max Joseph space, C-weight bodies, sawtooth rete-ridges, your answer will be definitely lichen planus. When you go home after this class, you will be solving multiple questions, and with these keywords you will be solving each and everything, right? So this is about the lichen planus. Okay, now these things will be showing a phenomena, that is also a question, and this is known as isomorphic phenomena. This is known as isomorphic phenomena. ठीक है, isomorphic phenomena होता क्या है? What is the meaning of that? This is also known as, what is the other name for this isomorphic phenomena? This is also known as Koebner's phenomenon. Koebner's phenomenon. So let me explain it. What is Koebner's phenomena? For example, I am having psoriasis, and here is the lesion, for example, and if I am scratching over here, what will happen? This particular type of lesion will appear here. This is known as iso, means same, morphology, morphic phenomena. That means there will be appearance of same type of lesion. Sir, where can you see these type of lesions? In three diseases. That is, your first one is your psoriasis, second one is your lichen planus, and third one is your vitiligo. So these are the diseases that would be showing you true cognirization. Okay, true cognirization. Sir, what is false cognirization or pseudo cognirization? बच्चों इसमें होगा क्या? Try to understand what will happen over here. The patient will be having like warts. It will be generally seen in viral infection. Patient can have warts. Patient can have molluscum contagiosum. Molluscum contagiosum is a viral disease. Now what will happen? The patient is having, for example, patient is having a pearly white umbilicated nodule. That would be molluscum contagiosum. Okay, here he is having a nodule, and when he is touching this particular part and again touching this part, what will happen? The virus can take up from this part and it can come to this part, right? And again the patient will be having an infection over here. There will be development of a lesion, but this is not a Kovner's phenomena. This is due to auto inoculation. Auto means self, the patient is inoculating himself, right? So that is due to auto inoculation. These things will be seen in warts and molluscum contagiosum. Okay, molluscum contagiosum, this is a very important question. Okay, lastly we are having this thing. You will be having this type of appearance, this type of mini bumps you will be finding. This is known as lichen nitidus, guys. This is known as lichen nitidus. You will be having, this is also known as mini lichen. This is also known as mini lichen. You will be having what? You will be having mini balls, mini balls like bumps on the extensor surface of elbow. On the extensor surface of elbow, you will be having mini tiny bumps on the extensor surface of elbow. You will be finding this type of thing. Okay, this when you are going to do the histopathology, you will be finding this particular type of appearance, and this is known as ball in claw appearance. Ball in claw appearance. This is the question they have asked you in your exam, that what is the ball in claw appearance is seen in which disease. Okay, that is your lichen nitidus, also known as mini lichen. This is your ball in claw appearance that you are finding. Okay, done. Now let's talk about the important one, that is your pityriasis rosea. First of all, whenever you will be looking at the term pityriasis का मतलब क्या होता है बच्चों? The meaning of pityriasis will be scaling. Okay, just try to understand the meaning. The meaning will be scaling. और scaling का मतलब क्या होता है? The meaning of scaling will be, scaling is a type of secondary change. Okay, scaling is a type of secondary change that I've already it is a type of secondary lesion that we have already discussed. There will be, it is a secondary lesion. There will be desquamation of stratum corneum. There will be desquamation of stratum corneum. Okay, so you will be having a mother patch. Very important question, guys. You will be having development of a single patch, that is known as mother patch. Then after that, what will happen? In this type of fashion, what will happen? There will be development of other patches, and this type of pattern is known as which type of pattern, guys? Try to answer. This is known as Christmas tree pattern. This is known as Christmas tree pattern. This is known as Christmas tree pattern. Yes, this is also known as fir tree pattern. Christmas tree pattern or fir tree pattern. And the patch is known as Herald patch. Herald patch, or also known as mother patch. Also known as mother patch or Herald patch. Okay. And these type of scales we are finding here, these are known as collarate of scale. Collar-like scale. Collar-like scale. Collarate of scales. Also known as cigarette paper scale. Cigarette paper like scaling. So we are having this type of scales present. Okay, let me summarize every type of scales here itself. Okay, we will be summarizing all the types of scales here. We are having silver white scale. You understand the meaning of scaling now. Scaling is a type of secondary lesion, right? There will be desquamation of stratum corneum. Stratum corneum will be lost. So silver white scales are feature of which disease? Try to answer. I am asking, try to answer. Okay, silver white scales are seen in which disease? Okay, second one, we are having fish like scaling. We are having fish like scaling. Fish like scaling is seen in which disease? Try to answer. Very good. Silver like let me ask everything. Okay, Greasy scale. We will talk about greasy scales. Greasy scales are the feature of which disease? Okay. And then you are having brainy scales. Brainy scales. Okay. And lastly, you will study about rice grain scale. Rice grain scale. So these are the important ones that has been asked in your examination. Now try to answer. First one, silver white scale is seen in psoriasis. Very good, guys. So wherever you are seeing silver white scale, your answer will be psoriasis. Second, fish-like scaling, we have already seen, sir, ichthyosis vulgaris. Ichthyosis vulgaris. Okay, so next, greasy scales. Greasy scales is a feature of, very good, Sneha. That is a feature of seborrheic dermatitis. Seborrheic dermatitis is nothing but the dandruff. Okay, dandruff will be having greasy scales. Seborrheic dermatitis. Brainy scale or rice grain scale, they are seen in one disease that is known as pityriasis versicolor. Pityriasis versicolor. Remember guys, this is pityriasis rosea. Rosea will be red structure. Okay, just try to differentiate. ध्यान से सुनो, just try to listen to me very carefully. Pityriasis simple meaning scaling. Here also the meaning of pityriasis will be scaling. We are having two types of pityriasis. One is rosea. Rosea will be giving red color. Rosea is for red color. Versicolor mean different color. You will be having that is common in trunk. That is a fungal infection caused by Malassezia furfur or Malassezia globosa. You will be having there hypo or hyperpigmented patches on the back. Hypo or hyperpigmented patches, right? And very characteristic appearance that you will be finding, that is spaghetti and meatball appearance. Okay, so that is a feature of pityriasis versicolor. Okay, pityriasis का मतलब समझ में आया? You understand the meaning of pityriasis? Now please try to move on to next is your identify the types of psoriasis in the given picture. Please try to identify, solve this question. How many says D, B? Some are saying D, some are saying B. So this is a red color structure. Can you appreciate? That is your erythrodermic. Very good guys. Rajveer, Saad. That is your erythrodermic psoriasis. Gutted. Why it is not gutted? In gutted, I have told you there will be gutta-like structure. And what is the treatment of choice for gutted? Because it is after upper respiratory tract infection, so that we will be giving antibiotics. Okay, pustular psoriasis, drug of choice we have already discussed. That is your acitretin. You will be having scaling plus pus. That would be your pustular psoriasis. Okay, for inverse psoriasis, the drug of choice will be methotrexate. Inverse means what? The psoriasis is present on your flexor surfaces. Okay, erythrodermic, the treatment of choice will be again methotrexate. Okay, now you understand drug of choice. Okay, try to answer this one. A 26-year-old male patient presented to OPD with, try to decode the information, erythematous plaque covered with silvery scales over extensor surface of both the arms. Punctate pitting was noted on the examination of the nail. What can be the diagnosis? Everyone is going in favor of A. That is your psoriasis. Multiple things are given. It most common side they are already given. They are that is your extensor surface. Silver white scale, that is a feature of psoriasis. Erythematous plaques you will be finding. Okay, pitting, which type of pitting? Superficial, deep, regular, irregular. Try to answer. Remember the Polish mnemonic. You will be having pitting. Which is that pitting? P for pitting, I for irregular pitting. You will be having which type of pitting? You will be having irregular pitting. Okay, irregular pitting. That is your deep irregular pitting. Superficial you will be seeing in alopecia. Okay, lichen planus, if the question wants to know about lichen planus, they must be giving you about the 5P or maybe pterygium. They should be giving you the history of plain, purple, polygonal papules. Apart from that, if they want to ask from histopathological examination, they will be giving you sevate bodies. They will be giving you Max Joseph cleft. They will be giving you sawtooth retinoides. Okay, so this is how you will be identifying the disease. Okay, eczema is type of a dermatitis. Pityriasis rosea, we have already seen. The meaning of pityriasis is scaling. Okay, what kind of scaling you will be finding here? If in the question they are writing collar rate of scale, sir, collar rate of scale or cigarette paper scaling. If they are writing collar rate of scale or cigarette paper scaling, then your answer would be pityriasis rosea. Okay, pityriasis rosea, mother patch, herald patch. Okay, this is how you have to remember. Okay, now we will be discussing about the different types of infection. Okay, what are the different kind of infections that we are having? Let's start one by one. We are having first one is your bacterial infection. Important points that has been asked in your examination. First of all, try to answer what is the causative agent for erythrasma. Erythrasma is due to Corynebacterium minutissimum. It is due to Corynebacterium minutissimum. Corynebacterium diphtheria causing diphtheria. Okay, what you will be finding, this is your wood lamp examination. When you are doing wood lamp examination, you are finding this coral red appearance. Okay, coral red appearance on wood lamp examination is a characteristic feature of erythrasma. This is a characteristic feature of erythrasma. The PDF will be given just after the class. Okay, please try to focus in the class first. Okay, second thing is your ecthyma pyogenicum. I will not take much of your time. Approximately 40 minutes we will be completing everything. Okay, don't worry about that. So we are having ecthyma pyogenicum, we are having ecthyma gangrenosum, ecthyma contagiosum. Pyogenicum will be causing due to pyogens, streptococcus pyogens. Gangrenosum is due to pseudomonas, and contagiosum is a viral disease that is due to parapox virus. Okay, so for erythrasma you have to remember Corynebacterium minutissimum. Which kind of appearance? Coral red appearance. Multiple times asked on wood lamp examination. Okay, next is your impetigo, guys. Impetigo, you will be finding in impetigo two types of impetigo we are having. One is non-bullous. Non-bullous means what? Bulla, you already know. Bulla is a fluid filled lesion. Here there must be some kind of a fluid filled lesion which is ruptured. Okay, here there is no bulla, so that is non-bullous impetigo. Here there is some kind of a bulla, that is bullous impetigo. Okay, now they will ask you about the cause. Okay, wood lamp examination is basically a type of light in which we are just looking inside that. Okay, उसके अंदर से हम लोग देखेंगे and then we will be identifying what we will be identifying different color, because this is a Corynebacterium minutissimum. It will be releasing an enzyme which is a keratolytic enzyme. Okay, it will be releasing a keratolytic enzyme, and because of that keratolysis there will be deposition of that keratin, right? And when we are looking under wood lamp examination, it is a handheld device, so when we are looking under that, we will be finding this type of color. Okay, this is what you have to remember. Okay, Sanjay, now we will be discussing about impetigo. Okay, two things we have to remember. One is non-bullous impetigo, second one is bullous impetigo. First of all, we need to remember what is the cause. Okay, here can you appreciate this type of crusting? This is known as crusting. Which type of crusting? This is known as honey colored crusting. This is known as honey colored crusting. Okay, this is known as honey colored crusting. Honey colored crusting we have already seen, it is type of secondary lesion. Crusting means what? There is some dried up exudate will be there. Crusting का मतलब क्या होता है? There is some dried up exudate, right? Now the most common cause for this particular situation is streptococcus. Strepto followed by staph. Okay, so the most common cause will be strepto. For bullous impetigo, the most common cause will be staph followed by strepto. They can be due to both, but this is how you have to remember this. Okay, so this is what it is. What you will be giving some antibiotics, and this can be done. Okay, now let's discuss about the cellulitis and erysipelas. Both of them are looking similar. Okay, when the patient is coming to you, both of these things will be looking similar. So how you will differentiate between a erysipelas and there is a cellulitis? Okay, so just remember, erysipelas is a superficial lesion. It is a superficial thing. It is due to group A beta hemolytic streptococci. It is due to GUPS or group A beta hemolytic streptococci. You will be having this type of sharp margin. Sharp margins will be there. Okay, and what else will be there? You will be having sharp demarcation. You will be having this sharp demarcations over there, right? Second one is your cellulitis. Cellulitis, remember, it is a deep entity. It will be going till your hypodermis. It is your deep lesion, and it will be going till your hypodermis. Remember, epidermis, dermis, basement membrane zone, and hypodermis. So this lesion will be going deeper. Okay, and it will be having no, it will be having non-demarcated margin. Non-demarcated margin. So basically, cellulitis is basically inflammation of cells. Okay, so cellulitis, the thing will be going deep inside. Okay, it will be penetrating all the layers. So it will be penetrating all the layers, whereas erysipelas will be superficial infection. When you are looking from outside, you will not be able to understand very clearly. You have to see for margins. If the margins are clear, if the margins are demarcated, look here, it is having demarcated margins. Here diffuse margins will be there. Okay, in cellulitis, the drug of choice that we are using for cellulitis is also amoxicillin. Okay, generally we are using amoxicillin for the infection. Clear, Sneha? Okay, so basic difference you have to understood. Once you started seeing the patient, you know what happens, you will be easily understanding things. Okay, you will be easily differentiating what is honey colored crusting. The baby is coming to you. Suppose in pediatrics OPD, you know what happens, the baby is coming to us, he will be having some honey colored crusting. You will easily identify this is due to streptococcus infection. Okay, right? Now we will be discussing about the fungal thing. Now we will be discussing about the fungal thing. First one is your pityriasis versicolor. Pityriasis meaning you already understood. The meaning will be, sir, pityriasis मतलब क्या होगा, मतलब will be, sir, scaling. There will be scaling. Okay, versicolor means you will be finding this type of hypo and hyper pigmented patches on the skin, on the back side of the trunk. You will be having this type of hypo and hyper pigmented patches. Okay, this type of hypo and hyperpigmented patches. Okay, now they will ask you about the causative agent. They have asked you question based on the causative agent. The causative agent is Malassezia furfur and Malassezia globosa. Malassezia furfur and Malassezia globosa are the causative agent. Most common site will be trunk. On the trunk, that is the most common site. Under wood lamp examination, when you look under wood lamp examination, you will be finding apple green color. Okay, apple green color. In erythrasma, which color was there? In erythrasma, there was coral red appearance. Here we are having apple green color. Apple green color. Okay, apple green color. On microscopy, you will be finding this particular appearance. This is looking like a spaghetti and meatball. Have you seen? Then you will be understanding that is your spaghetti and meatball appearance. For vegetarian people, we are also calling it banana and grapes appearance. We are also calling it banana and grapes appearance. Okay, so that is due to pityriasis versicolor, which is a type of a fungal infection. This is a type of a superficial fungal infection. Now let's talk about Petra, guys. Petra, those people, you must have seen Agori Babas, right? Those Agori Babas are having hair nodules, right? They are not very hygienic, right? So they will be having such kind of a like hair nodule infection, that is known as Petra. Okay, we are having two types of Petra. One is known as Pedra horte, that is black Pedra. One is black Pedra, and second one is your white Pedra. White Pedra. Pedra is a hair nodule infection. Okay, black Pedra is due to Pedra horte. Just remember, whenever we are wearing black, we look hot. So horte is due to black Pedra, and white Pedra is due to Trichosporon bigili. That is bigili. Bijli. Bijli is white. Bijli in Hindi, that is light. Light is white. Okay, so that is your white Petra, that is your black Petra. Okay, now we will discuss about the dermatophytes. Dermatophytes are superficial, again, skin infections. So we are having trichophyton, we are having epidermophyton, we are having microsporon. Trichophyton will infect all the three things that we have discussed today, that is hairs, nails, and skin. We have seen about hairs, we have seen about nails, we have seen about skin. So trichophyton would be affecting all these three structures. Okay, second one is your epidermophyton. Epidermophyton, just remember the letters. Okay, after E there will be H, so it will not affect H. Apart from that, it will be affecting nails, it will be affecting skin, right? Third one is microsporon. So after M there is N, so it will not affect N, okay, and it will be affecting your hairs and your skin. Just remember like that. Okay, in microbiology you must have seen the structures, pencil shape lesions, conidias, microconidias, you must have seen that. Okay, now we will be discussing about the tinea capitis. Because this is a rapid revision, we are going a little bit faster. If you are having any doubts at any point of time, you can always ask me. Okay, so we will be discussing about the skin infection. Basically tinea infections are like your skin infections. Okay, first one we are having this particular thing. I have told you tinea infection is of two type. One is inflammatory type, another one is non-inflammatory type. Okay, inflammatory type means it will be causing scarring type of alopecia. That means if there is infection, once there is infection, there will be no hair growth at that particular area. Okay, simple. So this one first, but look here, they will be giving you hint in the question, painful bogey swelling. First of all, try to understand. I have already told you acute infection will be bacterial, chronic infection will be fungal. Okay, so painful bogey swelling for 3 months, patient will come with the history like that. Okay, painful swelling on the head, there is a children, there is a boy who is coming, so you will be thinking in terms of carrion. Okay, you will be thinking in terms of carrion whenever you are finding this particular term, painful bogey swelling, you will be thinking in terms of carrion. Carrion is an inflammatory type of tinea capitis. What is the causative agent? What are the causative agent? Try to answer. We are having tinea mentagrophyte, and second one is your tinea verrucosum. The most important thing about this, let me teach you first. Okay, second thing is your this one is your dense crusting. Can you see? This is your dense crusting. If you are finding these words, dense crusting, scutula, this is due to favus. This is due to favus, guys. This is due to favus, and it is due to tinea snollen. The causative agent for this one will be tinea snollen. This one is also inflammatory type. Both of them are inflammatory type. Okay, then comes this one. This is your black dot. Can you appreciate these black dots? So this is your black dots. This is non-inflammatory, and then we are having gray patch. So this is also non-inflammatory. Okay, the most important thing that you have to remember is the drug of choice. For drug of choice for all the tinea infection in the body, you will be using what? Terbinafine. But the drug of choice for tinea capitis, if they are asking, then you have to answer in the terms of griseofulvin. You have to mark the answer griseofulvin. बच्चों यहाँ गलती नहीं करनी. You have to mark the answer griseofulvin. Okay. Then we are having these different teneas. We are having tinea cruris. We are having different names for them like Dobich. Okay. We are having different names. This one is your tinea corporis. Okay. This one is your tinea pedis. We can also call it like athlete's foot. This is basically due to moisture. Wherever there will be moisture, there will be tinea infection. Okay, tinea infection, those patients who are having tinea infection, what we are advising to keep the area dry. We are giving some kind of drugs like ketoconazole, azoles we are giving, luliconazole. So basically those azoles are static drug. Okay, those azoles are static drug. And second thing, we have to keep the environment clean and we have to keep it dry. Okay, so if it is dry, there will be no growth of this fungal infection. Okay, along with that, static drug we are also using, right? So these are the types of tinea. In tinea, you will always be finding central clearing, guys. Central clearing. For example, you must have seen the ringworm. Ringworm is basically a type of tinea infection, right? So you will be having central clearing in the tinea, in the ringworm. Okay. Second, central scarring is a feature of lupus vulgaris, which is a cutaneous TB. Okay. And central crusting is a feature of leishmania. Okay, leishmania, important. Now let's try to answer this one. The drug of choice for tinea, for all the tinea infection, the drug of choice will be terbinafine. For like skin infection, the drug of choice will be terbinafine. For tinea capitis, whenever there is an infection on the head, griseofulvin basically has more affinity for keratin. More amount of keratin will be present in your hair. Okay, so griseofulvin will be working very nicely on the hair infections. Okay, that is why we are using griseofulvin. Okay, take it, Sneha. Now let's talk about this one. This is your What is this? Try to answer. What is this? This is your sporotrichosis, guys. This is a subcutaneous infection. We are done with the superficial infection. Now we are going to talk about the subcutaneous infections, guys. Just a moment, guys. Just a moment. Let me take a break. Just a moment. Okay, guys. So this is about the sporotrichosis. Okay, this is about the sporotrichosis. Okay. So what will happen in sporotrichosis? What is the causative agent? Please try to answer. What is the causative agent for sporotrichosis? And what is this spread that is given here? Try to answer. Okay. So the causative agent for this one is Sporothrix shanki. Okay, this is the causative agent for sporotrichosis, and this type of spread is known as lymphocutaneous spread. Lymphocutaneous spread. Cutaneous means skin, lympho means along the lymphoid pathway, right? So that would be your lymphocutaneous spread. Okay, next thing, this is also known as Valentine disease. Very good, guys. This is also known as Valentine disease, also known as Rose Gardner's disease. These are the buzzwords, these are the keywords you have to remember. Okay, this is also known as Rose Gardner's disease. In the question, they will be giving you a history of a rose gardener who is plucking the roses. Around the Valentine, you have to pluck a lot of roses. That is why it is known as Rose Gardner's or Valentine's disease. He will be having thorn pick, and because of that, what will happen? He will be having development of this type of lesion that is known as sporotrichosis. And this type of bodies you will find in a histopathological examination, and these are known as asteroid bodies. Okay, how you will treat this particular situation? You can use, this is a fungal infection, so you will be using antifungal. Which is the drug that you are using here? The drug that you are using here is your itraconazole. The drug that you are using here is your itraconazole. Okay, itraconazole. Try to answer this one. What is this? Here again you will be having a thorn pick history. The patient will be given a history of a thorn pick, and apart from that, he will be having a development of verrucous lesion. Verrucous means what? Verrucous means warty lesion. Okay, verrucous cauliflower like lesion. Please remember, these are the important named structure. Very good. That is your chromoblastomycosis. This is your chromoblastomycosis. Mycosis means it is a fungal infection. Chromo means it will be having different colors. So you will be finding this type of infection here. This is a verrucous warty growth that you will be seeing after a thorn pick. Okay, woodworker का example दे देंगे. They will be giving you this type of example, and you will be having these type of keywords in the question. Okay, apart from that, these bodies they have asked multiple times. They are known as copper penny bodies. They are known as copper penny bodies. Names are important. You can call it copper penny bodies, but you can call it medlar bodies, muriliform bodies, sclerotic bodies. Okay, so names are important for this. They can give you any name: medlar body, sclerotic body, okay, muriliform body. So you can have this type of infection, right? How you will treat this particular situation? How you will treat this, but how you will treat this thing with particular drug? What is the drug that you will be using? Subhan, you can get me on my Telegram. That is a different thing. You have to. I will be answering you. Okay, it depends on the patient. It depends on the patient. For some people are having fungal infection for such a long time, like year long they are having fungal infection because they don't understand how to utilize. Itraconazole we are giving orally, and other drugs like luliconazole, ketoconazole, they are static drugs. Okay, they are static drugs. We are giving the patient these drugs. What patient will do? He will apply the drug. What will happen? There will be lesion will be gone, right? Lesion will be gone. There will be tinea infection will be normalized. After sometimes, what happens? He stopped the drug, and after sometimes there will be reappearance of the lesion because he is not cleaning the area. He is not keeping the area dry. Okay, that is how you have to treat. Okay, for treatment we will just remember the drugs for now. For now we will be discussing about the this part. Okay, if you want to know about treatment or other questions, you can ask me later on my Instagram or Telegram. Okay, this is about the parasitic infection. Let's talk about parasitic infection. Parasitic, the first one that we have to remember here, also drug of choice will be itraconazole. Okay, for parasitic infection, try to identify the disease that is given here. What is the disease that is given here? कौन सी disease है ये? Try to understand, try to look here. Circle of Hebra, these are the features. Burrows are the features of which disease, guys? This is your Sarcoptes scabies. Sarcoptes scabies is causing what? It will be causing, sir, scabies. Okay, scabies is due to a mite, and the most common area that it would be affecting is Circle of Hebra. This is the area that would be affecting much. Okay, this is disease known as scabies. Okay, scabies. Scabies, the other name for scabies are Prince H disease. The other names are Prince H disease, or also known as 7-year itch disease. If there is a scabies in a person, in a family, what happens? It is due to unhygienic situation. So what will happen? It will also transmit in the family itself. Okay, and what is the drug of choice? Before that, please look here. Burrows. What are burrows? Burrows are the most characteristic lesion here. Most characteristic skin lesion, that is burrow. Here you can see burrow. In burrow you will be finding the larva of these mites. Okay. Burrows will be present in your stratum corneum. Okay, this is a Norwegian scabies. Worst prognosis when you are using steroid. You know what happened? This is the Norwegian scabies that can happen, and the drug of choice for this one will be ivermectin, guys. Ivermectin. Norwegian scabies, we are using ivermectin, but drug of choice for normal scabies will be very, very important. Try to answer, guys. That is, please try to answer. What is the drug of choice for normal scabies? That is your 5% permethrin. 5% permethrin. Okay, this particular infection is your pediculosis. This is your pediculosis, and this is due to louse. This is due to louse. It is present in your head. If it is happening in your head due to unhygienicity, again it is known as head louse, pediculosis capitis. If it is in the body, we call it vagabond disease. We can also call it pediculosis corporis, okay, and if they are present in your pubis, that is known as, that is due to crab louse, okay. And the most characteristic lesion that you will be finding here is your macula seriola. Macula seriola is the most characteristic lesion that you will be finding here. And the drug of choice, again, here we will be using again permethrin, remember guys, but here we will be using 1% permethrin, 1% of permethrin, okay. The drug will be same, we can use permethrin lotion, but here we will be using 1%, okay. Here along with the scabies and scabies, we are also using other drugs also, okay, but the drug of choice will be 5% permethrin. Okay, now let's talk about this particular thing, viral infection. Please try to answer what is this. Whenever you are looking at this particular image, this is a pearly white umbilicated nodule. Whenever you are finding pearly white umbilicated nodule, your answer will be, bacho, what will be your answer? You will be marking it as molluscum contagiosum. Molluscum contagiosum. It is a viral disease that you will be finding in children, okay. Adults can also have this, but in the children, those people who are having low immunity, okay, those जो बच्चे होते हैं घर में, एक बच्चे को होगा, दूसरे बच्चे को भी हो जाएगा, right? So whenever a group of children are playing together, you know, those children who are having low immunity, these children will have this type of pearly white umbilicated nodule, that is your molluscum contagiosum, which is a viral disease, okay. These are the inclusion bodies that you will be finding here. These are the inclusion bodies, and these inclusion bodies are known as which bodies? Henderson-Peterson bodies, guys. Henderson-Peterson bodies. These are known as Henderson-Peterson bodies. And one phenomena that we have already discussed about this, that is your pseudo-Koebner phenomena. Pseudo-Koebner phenomena. Okay, pseudo-Koebner phenomena, what was that? Because of auto-inoculation. For example, the baby is the children is having a lesion over here, he's touching here, and then again he's touching the another children, he's having low immunity, he's having different things. So this lesion can occur in different person, but pseudo-Koebner means he will be having the same lesion on the different side of the body, okay, on the different side of the body. That is your pseudo-Koebner's phenomena. When you try to treat this situation, tell me the treatment also, guys. What is the treatment? You can use trichloroacetic acid, you can use podophylotoxin, and you can also use cryotherapy, okay. By liquid nitrogen, you can just freeze the lesion, okay, that is cryotherapy. You can also use imiquimod, okay. Next is your HPV infection. Let's talk about the HPV infection. It will be causing what? Sir, what is the mnemonic that we have to remember here? But you look here, the mnemonic that we are having is DSP, come eat a burger. Again, we are eating burger. We are always hungry, right? So DSP, come eat a burger. Okay, that is the mnemonic for this particular thing. So D for deep warts, S for superficial wart, P for plain warts, C for common wart also known as vulgaris, right? Common is also known as vulgaris, right? Next one, E for epidermodysplasia verruciformis. Sometimes you have seen the image of that tree man, right? Tree man, or there is an image with a like tree-like appearance, okay, of hands or legs. That is your epidermodysplasia verruciformis, okay. That is your HPV 5 or 8, okay. You have seen anogenital warts. This is also causing laryngeal warts also, okay. Laryngeal warts also. 6 and 11. Then 7 will be causing Butcher's warts. So that is 1, 2, 3, 4, 5, 6, 7, and you can remember like that, DSP, come eat a burger, okay. Apart from that, the most important that you are having is 16, 18 causing cervical cancer, okay. CA cervix, okay. CA cervix that you have already studied. We are having nowadays we are using the vaccination, that is nonavalent vaccine also available there. You can use Cervarix vaccine also, okay. So these are the important points about this particular thing, okay. Now we will be discussing about the mycobacterial infection. In mycobacterial, first one is your lupus vulgaris, okay. Lupus vulgaris, you will be, this is all this is the most common cutaneous TB. This is the most common cutaneous TB of cutaneous TB, okay. Cutaneous TB, this is the lupus vulgaris, okay. Second one is your scrofloderma. This is the second most common cutaneous TB in children. Okay, in children. So what is the feature that we have seen here? You will be finding central scarring. Central scarring will be there. Okay, and on diascopy, what you will be finding when you are doing the diascopy, you will be finding this apple jelly nodules. These apple jelly nodules you will be finding. Okay, you will be finding these apple jelly nodules. Central clearing was the feature of tinea infection. Okay, tinea infection. Okay, and central crusting we have seen is the feature of leishmaniasis. Okay, now we will be discussing about the leprosy, guys. Leprosy is due to Mycobacterium leprae. Sir, Mycobacterium leprae does not follow Koch postulate, right? It does not grow in normal situation. It will be grown in nine-banded armadillo. Okay, it does not follow Koch postulate, right? So first thing, leprosy is further divided into possibacillary and multibacillary. On the basis of what? So possibacillary means there will be 0 to 5 1 to 5 lesions will be there. 1 to 5 hypoanesthetic lesions means there will be less sensations. Okay, so 1 to 5 lesions will be there. If the lesions are more than 10, we can call it multibacillary. Second thing, if there is 0 or 1 nerve involvement, we call it possibacillary. If there are more nerve involvement, we call it multibacillary. 1, 2 or more, we call it multibacillary. Okay, on the basis of that we are giving the treatment. For possibacillary, the treatment will be for 6 months, and for multibacillary the treatment will be for 12 months. Same drugs will be given. What are these drugs? First one, rifampicin. Second, clofazimine. Third one is dapsone. Okay, rifampicin, clofazimine, D4 dapsone, D4 daily. These two drugs are given daily, and these two drugs are per month. Okay, so the patient will be coming to the coming to the hospital. The patient will be coming to the hospital, and the doctor will be giving rifampicin 600 mg and clofazimine 300 mg, and then we will be giving the packet to the patient, which is covering like dapsone and clofazimine 50 and dapsone 100. Okay, for daily purpose. Okay, then after taking drugs, you know what happens? The patient will develop some kind of reactions. Okay, and these reactions are known as lepra reaction. तो क्या करोगे? दवाई बंद कर दोगे? You need to stop the drug because patient is having reactions. No, we need not to stop the drug. We need to add some more drugs. Okay, so we are having type 1 lepra reaction. We are having two types of lepra reaction. We are having type 1. We are having बच्चों type 2. Okay, type 1 will be having which type of hypersensitivity? Type 4. Type 2 will be having which type of hypersensitivity? Just add 3. That we need to make it 5. So that would be type 3 hypersensitivity. That is 1 plus 4, 5. 2 plus 3. That is 5. That is how you will be remembering this. Okay. So for type 1 lepra reaction, the drug of choice will be steroids. You know what happens when the patient is taking these leprosy drugs? You know what happens? He will be having erythema. He will be having nodules generation on the body. Painful nodules will be there. So to subside all these things, what we need to continue the treatment. Along with that, we are adding steroids. Okay. In type 2 lepra reaction, we are adding steroids. Along with the steroids, we are also using another drug. We can also use another drug, and this has been asked multiple times, guys. Multiple times they have asked this question. That is your thalidomide. And there is a specific side effect of thalidomide that you will be finding. That is, it will be causing C-limb deformity, also known as phecomelia in the baby. Okay, phecomelia in the baby or C-limb deformity. Okay, and the classification that we are using for this one is your Ridley-Joplin classification. Leprosy के लिए जो classification use में लेते हैं, the classification that we are using for leprosy is Ridley-Joplin classification. Okay, we are having TT type of leprosy, we are having BT. Okay, we are having BB, we are having BL, and we are having LL type of leprosy. Two important you have to remember. BT type, BT कौन से लोग थे? Which people are giving BT? Those are like Indian people. So it is most common in India. Okay, second thing, satellite, who have sent the satellite very nearly, that is your satellite lesion is also with the BT. Just remember two things. Okay, BB you can remember geographical lesion. BB you can remember geographical lesions. You can also remember inverted saucer appearance. I would be telling you how the questions are coming. Just after this we will be solving the question. Okay, LL means what? Leonine facies. LN will be causing leonine facies. Okay, so this is a type of lesion. Can you appreciate? This is a lesion. Around the lesion there is another lesion. This is known as satellite lesion. Satellite lesion, and they will ask you which type of leprosy, then you have to answer BT type of leprosy. Okay, satellite lesion most common in India will be BT type of leprosy. Second, this is a geographical lesion, also known as inverted saucer appearance. Saucer appearance, inverted saucer is always concerned with the BV, so that is your BB. Okay, that is your BB, or geographical lesion will be BB. Okay, this is your leonine facies. Leonine facies, line like face, that is your LL type of leprosy, lepromatous leprosy. Okay, and this is your nine banded armadillo. This is nine banded armadillo. We don't have nine banded armadillo in India, so we are growing the leprosy, Mycobacterium leprae, in the footpad of newborn suckling mice. Okay, how much acid fast is leprosy? Can you answer? How much the acid fast is leprosy? How many percent H2SO4 will be required? Okay, try to answer this question. A farmer presented to you with a swelling on the foot. Multiple discharging sinuses are there. Granules from the discharge were examined under microscope, and you are finding what is the true regarding this situation. Try to answer this question. So basically, a farmer is coming to you, he is having some kind of swelling on the foot. Okay, there are multiple discharging sinuses, something is coming out, multiple things are coming out. Okay, discharge were examined under the microscope. When you are looking inside the microscope, what you are finding, what is true about this situation? First of all, you need to make the diagnosis, guys. Diagnosis kya hoga? The diagnosis will be mycetoma. Mycetoma can be eumycetoma, it can be actinomycetoma. Okay, eumycetoma, just remember after E there will be F, so that is due to fungus. Eumycetoma is due to fungus. Very good, guys. And actinomycetoma, A के बाद में B आता है, after A there will be B, so that is due to bacteria. Okay, fungal infection we cannot treat with antifungals, we have to do amputation. The treatment will be amputation. Okay, bacterial infection we can use antibiotics here. Okay, so it can be due to both bacteria, it can be due to fungus. Okay, it can be due to both the things. Okay, second question, they are giving you what is the probable diagnosis for a cauliflower shaped mass on the foot of a farmer. Okay, that appeared after a minor injury. There is some injury, after that what is happening, there is cauliflower like mass is appearing, and when we are looking under microscope, we are finding which type of body? Copper penny body. This is your chromoblastomycosis. This is your chromoblastomycosis. And sporotrichosis, you will be finding which body? Asteroid bodies. Okay, you will be having Rose Gardner's disease. If the history is like that, you will be answering sporotrichosis, but here the history is given in favor of chromoblastomycosis. Okay, before moving on to STD, that is your second last topic, I really want you to understand and identify which ulcer is which ulcer. Okay, can you identify which one is herpes? Can you identify which one is syphilis? Which one is donovenosis? Because in OPD, you know what happens, the patient will come to you directly, he will be just opening the things and telling you, sir, I am having this kind of ulcer. Now please identify and treat the situation. Okay, so before identification, you need to understand how to identify this type of ulcer. Okay, so first of all, you need to have a history. Okay, please try to answer which is this ulcer. Can you answer this ulcer? What is this ulcer? Can you answer this? I'm waiting for your response, guys. What is this ulcer? Can you answer this? You just need to understand the just give me 7 minutes and you will be understanding this thing completely. Okay, so first of all, what I've told you guys, you need to understand whether the ulcer are single or multiple. You need to understand this. Okay, we are having total 5 types of ulcer. We are having herpes simplex virus, that is causing herpes. Second one is your chancroid. Third one is your syphilis. Fourth one is your donovenosis, and then we are having lymphogranuloma venereum. 5 types of ulcer you have to remember, sexually transmitted diseases. Okay, positive agent for herpes will be herpes simplex virus. Okay, Haemophilus ducreyi is the causative agent for chancroid. Okay, syphilis, the causative agent will be Trypanosoma pallidum, and the lesion is known as chancre. Lesion is known as chancre. Primary syphilis, the ulcer is known as chancre. Okay, donovenosis, the agent will be Klebsiella granulomatis, and lastly lymphogranuloma venereum, the agent will be chlamydia. First thing I want you to know that this lymphogranuloma venereum, the ulcer will be transient ulcer. So when the patient is coming to you in the OPD, he will not be having that ulcer. Itna transient hota hai. Transient means what? The ulcer will be remaining for such a very less period of time. Okay, it will be disappeared. There will be only and only bilateral painful lymphadenopathy. Okay, so we need not to worry about this ulcer. Okay, we need to think in terms of all these four and how we will differentiate. First of all, we are having two methods. First thing, we need to identify the ulcer are multiple or single. These two ulcers are multiple. Herpes simplex and chancroid are having multiple ulcer. Okay, multiple ulcers are there. So can you appreciate, we are having here, we are having multiple ulcer, here we are having multiple ulcer, also here we are having multiple ulcer. These are single ulcer. This one is single and this one is also single. Clear? So how we will identify these multiple ulcers? They can be herpes simplex virus, they can be due to chancroid. Okay, so remember, I have told you in the first slide itself, the meaning of herpes will be grouped vesicle. Guys, use the terminology that you are having. Herpes का मतलब क्या होता है? The meaning of herpes will be grouped vesicle, right? Grouped vesicle, you already know. Vesicle is a clear fluid filled lesion. Vesicle we have already studied, right? That is a clear fluid filled lesion. That is grouped vesicle whenever you are finding. That is nothing but your herpes. Okay, here what we need to remember, this is your chancroid. This is your chancroid. How to remember, sir? You have to look for look for multiple things. First thing, you will be having this undermined edges. First thing, multiple ulcer will be there. Second thing, undermined edges will be there. Okay, undermined edges or unilateral painful buboes. Buboes, the meaning of buboes will be lymphadenopathy. Okay, if these things are given, then your answer will be Haemophilus do cry. Just remember, do cry. This patient will be crying. So this one will be painful ulcer. Herpes is also painful ulcer. Okay, just look here. Now you can easily identify two ulcers will be painful, other will be painless ulcer. Okay, so what we have learned till now, how do we identify? For herpes identification, we need to look for grouped vesicle. Second thing, for Haemophilus ducreyi identification, we need to look for undermined edges. We need to look for painful ulcer and unilateral buboes. This is what you have to remember. Okay, one side the patient will be having pain, he will be having multiple ulcers and undermined edges. Simple story, that is your chancroid. Okay, third thing, syphilis will be painless. All three ulcers will be painless. Okay, ये तीनों painless होंगे. So what you need to remember, syphilis will be painless and donovenosis will also be painless. Then how we will differentiate? These, both of these are painless ulcer, but this is your donovenosis, and this is your syphilis. This is your syphilis. How do we differentiate? In donovenosis, always in the question they will write you beefy red ulcer that will bleed on touch. If this terminology is written, beefy red ulcer, single beefy red ulcer, your answer will be always donovenosis, always donovenosis. Okay, in the question if they are writing shorty or rubbery or shorty, something like that, your answer will be syphilis, rubbery or shorty. You need to just remember the keywords. Okay, with this you will be easily identifying all the ulcer. For example, now let's discuss what will happen. A patient is coming to me, I'm sitting in my OPD, the patient is coming to me, he will be having all of these situations can happen, right? I will be looking at the ulcer. First of all, I will be excluding this. I will be asking whether you are having pain in the ulcer or not. So what I will see, is there any grouped vesicle? If there is no grouped vesicle, I will remove the herpes. Second thing, all three ulcers will be left. If they are multiple ulcer, I will be looking for chancroid. If they are multiple, then my answer would be chancroid. Okay. Second thing, if he is having single ulcer, I will be looking at the ulcer. I will be looking at the base of the ulcer. If it is bleeding on touch, I would be wearing the gloves. I would be touching, and if it is bleeding on touch, what will happen? That is a donovenosis ulcer. Okay, and syphilis ulcer will be single painless. Syphilis means painless ulcer. Okay, this is how you have to remember. And now doctor will now the patient will ask me, sir, please try to treat me as well. Okay, so any kind of urethral discharge or cervical discharge, the drug of choice will be, it will be treated by gray colored kit. These are the STD kit you will be studying in your PSM, in your other subjects as well, right? So you have to remember this, that is green colored for any kind of urethral or cervical discharge. It can be due gonococcal, it can be due to chlamydia. Okay, gonococcal I can treat like with cefixime, and azithromycin will be covering both the things. Okay, so things can be happening here will be gonococcal हो सकता है, non gonococcal हो सकता है. Non gonococcal most common cause will be chlamydia. Okay, drugs you have to remember. Okay, second is your vaginal discharge. If something is coming from vaginal, it can be due to trichomonas, it can be fungal like candidiasis, it can be bacterial vaginosis. Three possibilities can there. Okay, in short, like Suraksha clinic or STD clinic, I don't have all the facilities to check, right? So the patient will be coming to me, I will be thinking in terms of three things. Either it can be candida, sir, either it can be trichomonas vaginalis, either it can be bacterial vaginosis, right? So three things can be there. So fluconazole will be taking care for candida, and for both the parasitic like infections like trichomonas and bacterial vaginosis, secondidazole will be enough. Metronidazole we can give, but metronidazole we need to give for longer period of time, right? So we are using secondidazole. Third, I will be looking at the ulcer. Now the patient is coming with ulcer. Okay, he is coming with genital ulcer, and these ulcers are non-herpetic. First thing I am ruling out, herpes nahi hai. If there is no herpetic, means there is no grouped vesicle, then there will be three possibilities. LGV, the ulcer will be transient. I will not be able to see the ulcer. So it can be donovenosus ulcer. Okay, it can be chancroid. Okay, it can be syphilis. Okay, three possibilities can be there. For syphilis, the drug of choice will always be penicillin. Okay, for syphilis, the drug of choice will be penicillin. For chancroid and donovenosis, I can treat it with azithromycin. Single dose would be good enough for that. Okay, 1 gram and azithromycin I can give. Okay, but some patients are allergic to penicillin. Those patients who are having genital ulcer and patient is allergic to penicillin, what I can give in place of penicillin, I can use Doxy or azithromycin. Now we will be talking about ulcers which are herpetic. Herpetic means it is due to herpes simplex virus, due to infection. I will be giving acyclovir 400 mg TDS 5 days. Okay, 5 times a day TDS. Okay, that is your that is about the acyclovir. Okay, lastly we are having lower abdominal pain, PID, lower abdominal pain. I will be giving yellow kit. It will be having cefixime and metronidazole. Cefixime for bacterial infection, metronidazole for any kind of amoebic infection. Okay, and amoebic will be also taken care. Okay, lastly inguinal buboes are there. We can use azithromycin or doxycycline, that you have to remember. Okay, now please try to solve this question. These are the kits that you have to see once more, and just before the examination also. Okay, try to solve this one. Which type of human papilloma virus are classified as high risk? So they want to know about the squamous atypia. That is, they are talking in terms of cancer. When they are talking in terms of cancer, your answer would be HPV 16 or 18. They are the they are mostly associated with the cancer, that is CA cervix. Okay, squamous atypia. Next question, a 45-year-old truck driver, they are always obsessed with the truck driver, with a history of multiple sex partner, presented to the dermatological department. As shown in below, what would be the likely diagnosis? So lichen planus cannot be the answer, you can rule out. Scabies cannot be the answer. Psoriasis cannot be the answer. Your answer will be secondary syphilis, and in secondary syphilis you will be having moth eaten alopecia. Along with that you will be having condyloma lata. You will be having lesions on palms and soles. Okay, that is your secondary syphilis. In primary syphilis you will be having chancre, that is genital ulcer. Secondary syphilis, condyloma lata. Tertiary syphilis you will be having genital, that is your gamma. In tertiary syphilis you will be having granuloma, that is gamma. Okay, next we are having vesico-bullous disorders. We are having two things. One is pemphigus group of disorders, second one is your pemphigoid group of disorders. Okay, pemphigus or pemphigoid mein how we will differentiate? Pemphigus, just remember S for it is superficial. Just remember what I am telling you, it is a superficial lesion. Okay, what are the layers that we have studied? That is, come let's grab some burger. Okay, pemphigoid, bullous pemphigoid is a deep blister. Okay, how we will remember? Just remember the one word. In pemphigus, what is happening? There is formation of antibodies. Antibodies are formed against desmosome. Desmosome. In pemphigus, IgG antibodies are formed against desmosome, and which desmosome? That is your desmoglein. That is your desmoglein. Okay, and this type of lesion will be having what bulla? They will be having flaccid bulla. Flaccid bulla मतलब क्या होगा? They will be superficial, so they will be ruptured easily. Okay, here it is a deep lesion. So what is happening? These keratinocytes are binded together with the help of desmosomes, but these keratinocytes are bind to the basement membrane with the help of hemidesmosomes. So hemidesmosomes like BPAG1 and BPAG2, bullous pemphigoid antigen 1 or 2. So here the lesion will be here. The lesion will be deep. So that would be giving you which kind of bulla? Tense bulla. If you not understand anything with this slide, just remember two terminology. Flaccid bulla, pemphigus, S for superficial. Tense bulla, pemphigoid, D for deep. Simple story. Okay, you have to remember this much at least. Okay, now what will happen? Try to understand. Now let's talk about the pemphigus. Very important slide, guys. It will take five more minutes and you will be understanding this. Okay, so pemphigus hoga kya? Pemphigus, we are having two things: pemphigus foliaceus, and second we are having is pemphigus vulgaris. Okay, we have already seen foliaceus will be desmoglein 1, vulgaris will be desmoglein 3. Antibodies are formed against desmoglein 1. 1 is first for foliaceus, and here 3 will be for the vulgaris. Okay, how you will identify? This is your come, let's grab some burger. This is the layers of epidermis. Pemphigus is always in the epidermis because desmosomes are present in a stratum spinosum. So pemphigus always we will talk about epidermis, whereas bullous pemphigoid we will talk about basement membrane zone. Okay, after 5 minutes you will be understanding what is that. Okay, so we are having this desmoglein 1 antibodies, IgG antibodies are formed against desmoglein 1. Here also IgG antibodies are formed against desmoglein 3. Clear till now? Now what will happen? There will be lesion in which layer? Lesion will be in the stratum granulosum, and this is the most important thing you have to remember from this particular session. Okay, इस पूरी क्लास में से ये एक ऐसा पार्ट है जहाँ से क्वेश्चन आते हैं. Okay, that is your stratum granulosum. Okay, and here the lesion will be in stratum spinosum. Mainly the lesion will be in stratum spinosum. Now what you need to remember, stratum granulosum, I can also call it subcorneal bulla. I can also call it subcorneal bulla. Here the lesion will be in stratum spinosum. So can I call it suprabasal? Yes, I can call it suprabasal bulla. So just remember, for vulgaris we can also call it suprabasal. If you just remember these two terminology. Okay, vulgaris will be suprabasal, foliaceus will be subcorneal. Simple things. Okay, now what will happen? For all the types of pemphigus, you have to remember this mnemonic minar. Okay, sir, what is pemphigus? Ho kya raha hai? You are not telling us what is pemphigus. So basically I have told you we are having two keratinocytes. They are binded together with the help of desmosomes. This is the keratinocyte. Now what is happening? This desmosome is gone away, right? There is antibody against desmosome. Now what will happen? These two cells, these two keratinocytes will be fell apart, and this is what is happening here, right? This is known as pemphigus. This is known as pemphigus. Okay, इसी को pemphigus बोलते हैं. Now what is the mnemonic that we have to remember for all the types of pemphigus? That is minar. We are having mucosal involvement. That is seen. I for they are intraepidermal. They are intraepidermal bullae. N for they are Nikolsky positive. A for acanthocytes. Acanthocytes are basically keratinocytes, normal keratinocytes you will be finding, and R for row of tombstone appearance you will be seeing. Row of tombstone appearance you will be seeing. Row of tombstone appearance you will be seeing. Now I will be explaining you with the help of images what are all these things. Okay, so you have to remember minar. So this is your Nikolsky sign. Nikolsky sign is when we are putting the tangential pressure, there will be some kind of a rupture. Okay, so that is Nikolsky positive. Nikolsky mein what we are going to do? We are putting tangential pressure. Okay, second one is your Absoy-Hansen sign. Absoy-Hansen sign, I will be summarizing everything for you. Absoy-Hansen, also known as bulla spread. So basically, when you are putting perpendicular pressure to the bulla, what will happen? It will spread out. It will spread out. That is known as bulla spread sign. It will be positive for Nikolsky and bulla spread sign. Next, we have seen the row of tombstone appearance. Can you appreciate? These are the tombstones. Okay. Can you appreciate this type of structure over here? These are looking like a row of tombstone. This is known as row of tombstone appearance. Okay, this is known as row of tombstone appearance. Apart from that, when you see on histology, you will be finding acanthocytes. Acanthocytes will be present here, right? And this is the DIF, direct immunofluorescence. When you are doing, you are finding this particular type of pattern. Try to see what we have learned till now. So guys, can you appreciate what is rete? So this is the part of epidermis which is invaginating into dermis. This is your rete, okay, and this is the part of dermis which is going into epidermis. This is known as dermal papilla. Let me orient first. Okay, above portion will be above this portion will be epidermis. This one is your dermo-epidermal junction, and lower will be dermis. Okay, this is what the story is. Okay, now what is happening? You are finding these are nothing but your keratinocyte. Basically, look here what is happening. So this is a keratinocyte, another keratinocyte. These are all keratinocytes. They are binded together with the help of desmosomes. They are desmoglein. Now what is happening? Some antibodies are formed against this desmoglein, and this is the antibody which is giving you this type of appearance. Okay, this is the immunofluorescence that we are seeing, and this is because these are all keratinocytes. These are all keratinocytes binding together with the help of what? Can you appreciate? This first layer will be stratum corneum. Just like that, we are having stratum spinosum. In a stratum spinosum, you will be having multiple keratinocytes binded with the help of desmosomes. Now these are the desmosomes against which what is happening? There is antibody deposition, right? Understood, guys? So that is giving you a particular appearance that is known as fishnet pattern appearance. Very important question. Fishnet pattern appearance is due to deposition of IgG antibodies. Is due to deposition of IgG antibodies. But second, now we are done with the pemphigus group of disorder. Second one is your bullous pemphigoid. Can you appreciate? This is again epidermis. This is dermo-epidermal junction, and this is dermis. Okay. Now what is happening? The antibody is depositing in this particular area. Why? Because I have told you bullous pemphigoid will be due to hemidesmosomal proteins like BPAG2 or BPAG1, and these are present on hemidesmosomes. Hemidesmosomes kahan the? We are having hemidesmosomes here. We are having hemidesmosomes here. So that is why we are having this particular type of pattern. Now you can see DIF and easily identify that fishnet pattern will be seen in pemphigus, because pemphigus is a disorder in epidermis, whereas this linear type of pattern you will be seeing in bullous pemphigoid because it is hemidesmosomal thing that is happening, right? Here you will be finding what kind of bulla? You will be finding tense bulla. Here you will be finding tense bulla. Here in question you will be finding always flaccid bulla, because they are flaccid means what? They are easy to rupture, because they are present in epidermis. They are easy to rupture. Okay, whereas these bullas, these are present in your dermis. These are present in your dermoepidermal junction, so they will be tense bulla. They will be tense bulla. Okay, one more differential you have to do, that is your linear IgA disease. Sir, linear IgA disease is also giving this linear type of pattern, but you have to remember here the antibodies are IgA. This is how you will be differentiating. The antibodies are IgA, whereas in bullous pemphigoid the antibodies are IgG or C3 deposition will be there. Okay, C3 deposition or IgG will be there. Okay, along with that, in linear IgA you will be finding this particular type of appearance. This is known as string of pearl appearance. String of pearl appearance. Okay, this is also known as string of pearl appearance. Next we are having is dermatitis herpetiformis. Dermatitis herpetiformis. We have already seen in dermatitis herpetiformis you will be finding this dermal papilla. Now you understood this is your rete, and part which is going upward, that is your dermal papilla. That is your dermal papilla. In dermatitis herpetiformis you will be having papillary tip microabscess. You will be having papillary tip microabscess. Okay, basically what is happening, you will be having neutrophilic infiltration. Neutrophilic infiltration, we have already discussed this in the abscess, in the micro abscesses. Okay, it is associated with HLA. It is associated with HLA B8, DR3 and DQ2. It is associated with HLA B8, DR3 and DQ2. It is also associated with a disease that is known as celiac disease. Celiac disease. It is also associated with celiac disease. Okay, and what are the antibodies that are associated here is your anti-gliadin, anti-TTG, or anti-endomysial antibody. Anti-gliadin, anti-TTG, anti-endomysial antibody. Again, you can remember dermatitis is inflammation of dermis. Herpetiformis, look here, herpeti means grouped vesicle. On the extensor surface, you will be having this type of grouped vesicle. Okay, so that is your dermatitis, herpetiformis. It will be having association with celiac disease. The drug of choice for celiac disease will be dapsone, sulfonamide, that is dapsone. And the treatment of choice that you already know, that is avoiding bro. Okay, you need to avoid barley, rye, oats and wheat. Okay, that is the treatment. Now we will be discussing about the question, what is the probable diagnosis for a 30-year-old patient who is presented with flaccid bulla? Try to identify flaccid bulla in her skin that are easy to rupture with a biopsy showing suprabasal split. And this type of questions you are marking wrong, and that is the purpose I am telling you. Suprabasal means what? The lesion, what we have discussed. Come, let's grab some burgers, right? What we have discussed till now, let's see one by one. Suprabasal means what? Where is the problem? Problem lies in the stratum spinosum, and we have already seen in the stratum spinosum there will be maximum desmosome, so it is always concerned with desmoglein 3, and desmoglein 3 is concerned with vulgaris. Whereas when we talk about this one, subcorneal, when we talk about this one, that is your desmoglein 1 is involved there, and the disease will be foliaceous. How you can remember? If you don't know the answer, how you will get to the answer? Okay, erythema multiforme, no, there is no correlation. Vegetans, we don't know. We are confused between like vulgaris and foliaceous. That is what we have studied. So desmoglein 3 will be vulgaris. Whenever they will talk about suprabasal split, suprabasal or split in the spinosum, your answer will be this 2 will be vulgaris, and above that will be foliaceous. Just remember like that. Okay, this is the most important point you have to remember. Now try to solve this one. What is the probable diagnosis for a 65-year-old male patient presented with itchy, tense bulla on his limbs, which eventually collapse after a few days? Now they are talking about which type of bulla? Tense bulla, guys. Tense bulla, the answer will be very good, Saad. Very good. In nomine valproate, Sanjay. Okay, so your answer will be bullous pemphigoid. Reason means, bulla means what, sir? There is some fluid filled lesion is already there. Apart from that, vulgaris cannot be the answer, because it will be pemphigus will be having which type of bulla? Flaccid bulla. Okay, dermatitis herpetiformis, sir, herpetiformis, there must be some grouped vesicles. Okay, and linear IgA dermatosis, linear IgA disease is also a different entity. Okay, so your answer would be A. Now you guys are understanding, confidence are, you will be solving this type of questions very easily. Just revise this once again and you will be able to solve most of the questions. Okay, we are done with most of the things. Now last 10-15 minutes I will take, don't worry, and we will be done with the session. Okay, so we are going to discuss about the pigmentary disorders now. Okay, so we are going to discuss about the pigmentary disorder. First one, try to identify what is this situation. Very good, guys. That is your melasma. That is your melasma, and melasma is due to excessive melanin deposition. Excessive deposition of melanin. Very good, guys. Second one. This is your which sport is this? This is your Mongolian sport, guys. This is your Mongolian sport. Okay, is it self-limiting situation or we need to treat this particular situation? Please let me know. Okay, general most common site is back side of trunk. Back side of trunk. How do we treat this? Is it treatment or self-limiting? Very good, guys. It is a self-limiting thing. It will be resolved within 1 year. 1 year, right? This is the question they have asked. Okay, this is around an ophthalmic nerve. This is known as nevus. The meaning of nevus will be discoloration. Nevus of ota. This is a nevus of ota that you will be finding bluish discoloration. Bluish discoloration of eye. Okay, that would be ophthalmic thing. Okay, try to answer this. This is your acanth. Acanth means we are talking about stratum spinosum. Acanthosis means there will be thickening of stratum spinosum. And acanthosis nigricans means this is a finding that you will be associating with certain diseases. It will be telling us about the internal malignancy, also telling us about certain other things, diabetes mellitus and internal malignancy. Okay, insulin resistance, right? This one is your, again, discoloration is there, so it is also a nevus. But which type of nevus is this? Nevus of ito. This is your nevus of ito. This is also a discoloration, so there will be nevus. What kind of nevus? You will be seeing this type of hairs. Okay, so if bal in Hindi, hairs are bal, so that is, if bal is there, that is your Baker's nevus. Okay, that is your Baker's nevus. You can appreciate here that discoloration is here, right? So that is your Baker's nevus. Okay, try to solve this one. Miscellaneous topics, last topic we are discussing. This is your, what is this we call it? This is known as, this is a disease, pyabaldism. Okay, and this particular thing is known as what? These are known as white forelocks. Very good. Very good, Sneha. That is known as white forelocks. White forelocks. You have seen this particular thing in which like political leaders. That is your Indira Gandhi. Okay, Indira Gandhi has this thing. Okay, that is your white forelocks. Okay, white forelocks. Why this thing is happening? Pyabaldism is due to absence of melanocytes, guys. If there is no melanocyte, there will be no melanin. There will be no melanin. There will be no color, right? So it is a type of autosomal dominant condition, guys. It is a type of autosomal dominant condition. Okay, now let's talk about vitiligo. Vitiligo also, there will be absent of melanocyte. What will happen here? We are having different types of vitiligo and they are giving you the image. So how to identify? We are having localized, we are having generalized. Okay, localized, if it is present on certain parts, okay, that is your focal. Without symmetry, certain parts, if it is present, that is your focal thing. Okay, second one is your segmental. Along a nerve segment will be segmental. Along a nerve segment will be segmental. In generalized, we are having acrofacial. Generalized will be bilateral. Look here, generalized will be bilateral. This is how you will be identifying. Acrofacial means acro means extremities of the body, and facial means face will be involved. Okay, vulgaris, you will be having most common, both bilateral side there will be multiple lesions. Okay, you can appreciate these multiple lesions on both the sides. And universal, that means most of the body will be covered. Most body will be covered. When you solve question next time, you will be identifying. Just revise it once again. Okay, here also there will be melanocyte problems. This one is your, what is this girl is your albinism. Okay, this is a this is a girl which is completely white. That is due to absence of melanogenesis. Guys. Okay, melanin is formed from what? Tyrosine. बच्चों, melanin किससे बनता है? Tyrosine. So tyrosine will be making melanin, and melanin will be giving what? Tyrosine will be making what? Epinephrine, norepinephrine, dopamine, melanin, all your catecholamines, right? So it is due to an enzyme that is known as tyrosinase enzyme, right? And this tyrosinase is defective in melanin problems, right? And this is a autosomal recessive thing. Remember, guys, this is autosomal dominant, this is autosomal recessive. Okay, you have that table of autosomal dominant and recessive things. Now we will be discussing about last 2-3 slides. These are the last 4 slides. Okay, we will be discussing about the certain images that we are having. Okay, So first of all, let's see one by one. First thing, can you appreciate what is this? This is your cerebriform nucleus. Cerebriform nucleus. I want you guys to be very active. Albinism will be complete body will not have the, look here, complete body will be white, that is albinism. Vitiligo will be certain parts of the bodies will be having absence of melanin. Okay. Next one is your cerebriform nucleus. Okay, it will be having which cells? It will be having Sézary cells. Okay, Sézary cells and Sézary cells, cerebriform nucleus, they are the feature of what? So they are the feature of what? Sézary cells, cerebriform nucleus, they are the feature of cutaneous T cell lymphoma. Cutaneous T cell lymphoma. Cutaneous T cell lymphoma, also known as mycosis fungoides. What kind of abscess have you seen here? You have seen Pottier's abscess. Okay, Pottier's. Last one we have seen, that is your lymphocytic abscess. That is your Pottier's abscess. Pottier's abscess. Okay, this is your Harlequin baby, guys. Try to see this Potter's. This is your Harlequin baby. Okay, what is the gene involved here? That is ABCA12, ABCA12, ABCA12. Okay, this is your dermatomyositis. Derma is involved, myo is involved, itis means there is some kind of inflammation. Okay, here you will be finding, look here, here we are having those erythematous and edematous lesions will be there. This is particular thing that is known as Shawl sign. This is known as Shawl sign. Okay, and on MCP you will be finding this type of papules. These are known as Gottron's papules. Very important. Gottron's papules is a feature of, okay, that is dermatomyositis. Okay, you will also be finding mechanic hand. Mechanic hand kya hota hai? What is mechanic hand? There will be thickening of stratum corneum. Stratum corneum thickening is known as mechanic hand. Stratum corneum thickening is known as that is known as mechanic hand. This is your staphylococcal scalded skin syndrome, that is due to some toxins. What are the toxins, guys? These are due to toxins of staph. What are the toxins? We are having epidermolytic toxin. We are also having we can also call it exfoliative toxin. Okay, we will be discussing about all these things in microbiology. You can join that session also. Okay, so that is your epidermolytic toxin. We are also having exfoliative toxin. Okay, 10 will be having toxic epidermal necrolysis. It will be having connection with some drugs like phenytoin. Okay, it can be having connection with lamotrigine. Okay, it can be due to some NSAIDs also. Okay, there is also one more thing, that is Stevens-Johnson syndrome. Less than 10% of the body area will be covered there. It can be due to also due to drugs. Okay, this is your 10. More than 30% of area will be covered. Okay, that is your 10. Can you appreciate this? This is a nerve segment, and these are multiple grouped vesicle. So this is your herpes zoster infection. Herpes zoster infection due to reactivation, and that you will be finding. This is also known as shingles. This is also known as shingles. Okay, this is also known as shingles. Sézary cells are the cells you will be finding in cutaneous T cell lymphoma. Okay, cerebriform nucleus will be there. Okay, so this is about the shingles. Let me teach you the doses of the treatment also. We are giving 800 milligram 5 times a day into 7 days, because it is a painful situation. Thoracic nerve roots are most commonly involved. Okay, this is how you will be finding. And this is your patch test, guys. Patch test for allergic allergy. We are doing this patch test, and the reading will be taken 48 to 96 hours. Okay, reading will be taken 48 to 96 hours. 96 is the most common. You have to mark the answer. Okay, agar 96 option mein, then you have to mark this answer. Okay, next one we will be discussing about certain skin cancer. We are having, yes, that is day 2 and day 4. If day 4 is there, we need to mark that. Okay, then we are having basal cell carcinoma, squamous cell carcinoma, and melanoma, guys. Okay, first of all, look here. Basal cell carcinoma is also known as rodent ulcer. क्या भी बोलेंगे? rodent ulcer बोलेंगे, and this is the most easy to treat. You just need to excise it. You just need to excise it, and that would be gone. Okay. Second thing is your squamous cell carcinoma. That is most common squamous cell carcinoma is carcinoma you will be finding where? On hand, right? You will be having firm nodule like patch. Okay, you will be finding that. It is also a severe thing, but the most severe that you will be finding here is your melanoma. Melanoma, we are checking A, B, C, D, E for melanoma to distinguish between melanoma and mole. Okay, how do we differentiate between a melanoma and a mole? And melanoma are not very easy to treat. They are very hard to treat. They will spread, right? They will spread to the body. The most common and easily treatable is your rodent ulcer. Okay. Now let's see. This is your xeroderma pigmentosa. Xeroderma pigmentosa. These patients cannot go outside in the sun. Okay. They cannot tolerate the sun. These patients will be having a defect which is a nucleotide excision repair defect. They will be having nucleotide excision repair defect. Excision repair defect. Okay, they will be having nucleotide excision repair defect. That is, you have to remember. Okay, now this one is your lupus pernio. Here, look here, nasolabial fold is also involved, whereas look here in SLE we don't have nasolabial fold involvement. Okay, so this is how you will be distinguishing between these two things. Okay, this is your Raynaud's phenomena. This is your sequence will be white, blue and red. They have asked you in the examination what would be the sequence. Sir, white is due to ischemia. Because of ischemia, what is happening? Blood supply is not getting there. Because of that, it will be coming white, right? Then blue is due to cyanosis, and red is due to regain of the blood vessel. Okay, that is due to regain of the blood supply, and that would be changing the color into red. It can be due to multiple things. So that is your Raynaud's phenomena. Okay, sclerodactyly. Here you can see. Can you see pitting? There will be pitting with scarring. Sclero means there will be scarring. Okay, sclero means there will be scarring and there will be some kind of pitting. Okay, this is your pyoderma gangrenosum. It has the most common association with two important diseases that you have to remember. First one is your ulcerative colitis and second one is your Crohn's disease. Important points I'm telling you. Important one is your ulcerative colitis and Crohn's disease. What are the appearance that you will see in ulcerative colitis? You will be having skip lesion. Crohn's kahin bhi ho sakta hai. Remember, Crohn's can happen anywhere in the body. It will be having skip lesions, whereas ulcerative colitis will be starting from the below. You will be having lead pipe appearance in ulcerative colitis. In Crohn's disease, you will be having string sign of Cantor. Okay. Okay, look here. We are having contact dermatitis. We will be talking about that. So here, can you appreciate this part is having allergic contact dermatitis? That means something is coming in contact. So what thing can come in contact? That is your anklet. And anklet is having what, sir? Anklet is having nickel and copper. Okay, so it is due to nickel. It is due to nickel and copper. Those people who are wearing those artificial anklets, okay, they will be having this type of reaction. Okay, this is which type of hypersensitivity? Remember guys, this is type 4 hypersensitivity. This is a type 4 hypersensitivity. But just remember one more thing, atopic dermatitis is always a type 1 hypersensitivity. It is a type 1 hypersensitivity. Okay, next one is your irritant contact dermatitis. Those people who are like washing their hands with like detergent, you know what happens? They will be having this type of irritation. Okay, and that would be causing irritant dermatitis. Okay, this one is your osteotic eczema or xerotic dermatitis. Because of that, basically these are dermatitis. The simple meaning will be there will be inflammation of the skin. Okay, it is perioral because of nerve, that is neurodermatitis. Seborrheic dermatitis you will be having on this scalp, right? What kind of scaling you will see in seborrheic dermatitis? You will be finding this. Can you appreciate these greasy like scales? In baby we call it cradle cap appearance. Basically it is a dandruff, right? So you will be finding this seborrheic dermatitis and you will be having greasy like scaling. Okay, patch test we have already discussed, day 2 or day 4. Okay, you will be taking the values. Okay, and this is your nummular dermatitis because this is a coin shaped lesion. This is a coin shaped lesion. So basically these are the different types of dermatitis. I will be telling you the causes, right? What are the causes that you have to remember? Very important table. Okay, these are the causes and you will be having in last 3 or 4-year examination, you will be having approximately 7 to 8 questions from this table. Okay, so we are having allergen, we are having source, nickel, cobalt, metal. They will be causing allergic contact dermatitis, and they are having in the artificial jewelries, you will be having in jeans or buttons. Generally the patient, the females will come to us with the artificial jewelry, and she will be having some dermatitis because of that. Okay, that is basically a allergic contact dermatitis. Okay, cement, what is the constituent that you will be finding in cement? That is your chromium. In paint you will be finding potassium dichromate. In plant you will be find in plant, which plant is that? That is your parthenium. Parthenium, also known as congress grass. Congress grass. Okay, hair dye you will be having what? PPT. PPD will be present in your hair dye. Topical medicine will be having neomycin. Latex and rubbers will be present in your gloves. And PTBP, just remember butyl, para tertiary butyl phenol. That will be for B. You can remember butyl will be present in bindi. Okay, that is how you have to remember. And now lastly we are distinguishing between a melanoma and a mole. How we will distinguish, sir? We need to check for melanoma. We will be ruling out with the help of A, B, C, D, E. They have already given question based on this, but now they can give the question and they can change any of the option. Okay, so A for asymmetry, just remember it can be asymmetrical. I'm talking about melanoma. B for they will be having borders, that would be irregular borders. C will be they can be changing the color. Okay, D means diameter, that would be more than 6 millimeter. Okay, and lastly it will be evolving, that means it can change the size, it can change the shape, it can change the color as well. Okay, so it can change anything. That is how we are differentiating a melanoma and a mole. Okay, with this we are done with our dermatology, guys. This is my Instagram, this is my Telegram. You will be getting PDF. Okay, here also I will be sending at other platform also. Okay, thank you so much for all your patience, and please try to revise whatever we have studied. I think just try to revise everything. Exam is too much near. Please try to take care of your health, try to eat good food, and try to sleep on time. Okay, so let's recap what we have done. We have done the basics of dermatology. We have seen different skin appendages, papilloscomus disorder. Now I think you must be knowing about lichen planus, psoriasis, lichen planus. You have known about infection, bacterial, parasitic, and fungal, all those infections. Your STDs, I know, I really hope you guys are understanding how to differentiate between ulcers. Vesicular disorders we have seen, pigmentary, hyperpigmented, and miscellaneous topics. Okay, along with that, just try to solve some important questions. I have already done a video on that for PYQs as well. Okay, you can also watch that. Otherwise you can solve questions from your book or whatever source you are having, and just complete this subject. Okay, thank you so much, guys. So good night. If you are having any doubts, you can always reach out to me. These are my handles. Okay, thank you.